Recording in progress.
YouTube. На YouTube.
Не трансляции.
Mhm. Bună dimineața, stimați colegi! Da.
Bună dimineața!
S-a primit totul?
Bună dimineața!
Bună dimineața, domnul profesor!
Oh, ce plăcere să ne auzim! Vă îmbrățișez pe amândoi, vă văd pe voi momentan și salut pe toți cei care mai sunt cu noi.
Bună dimineața!
Mulțumim!
Dimineața!
Deja sunt 82 de participanți, dar cred că vor fi mai mulți. Sunt înregistrați 315 participanți.
Da. Perfect, e minunat. Când intrăm?
La 9 și 15 mai sunt 7 minute.
Da, e bine, e bine. Putem verifica dacă merge share screen-ul?
Da, sigur.
Da? Funcționează?
Merge totul bine. Bună ziua, echipa tehnică. Merge super.
Echipa tehnică minunată. Mulțumesc foarte mult. În ordine.
Doar domnul Datin, vă rog să dați full screen. După ce faceți share screen.
Sigur. Să vedem acum un moment. Suntem în ordine, da? Funcționează.
Super, e perfect.
Perfect.
Mulțumim.
Eu mulțumesc foarte mult. Am făcut și proba, așa că suntem în ordine.
Domnul profesor Mureșanu, onorat,
domnul
vă salut,
profesor,
vă salut.
Ce plăcere, nu v-am văzut.
Vă salut.
Vă îmbrățișez.
De asemenea, sunt bucuros să vă văd, să vă aud.
Domnilor profesori și dragi prieteni, vă îmbrățișez cu mare, mare bucurie să fim împreună. Așa, a limitat, dar ce să zic, asta e viața acum.
Da. Cum e timpul la Cluj?
Timpul e bun, timpurile
nu prea.
Grele.
Timpurile grele, da.
Da,
și la Chișinău e o zi superbă.
Da.
Aș fi fost cazul astăzi să fim împreună aici și să ne plimbăm, să mai degustăm.
Ce plăcut ar fi fost. Din păcate, la noi acum văd că explodează cazurile astea noi și e foarte rău.
Să știi că și la noi e o situație teribilă, foarte multe cazuri, 1000 și ceva, tineret, spitalele sunt pline, e groază.
Foarte mulți vaccinați, din păcate.
Sunt și vaccinați, fac forme mai ușoare, dar fac.
Da, din păcate și vaccinați.
Da.
Ce să facem? Asta este,
da.
Trebuie să fim atenți și
da.
În ordine. Eu am cam 5-6 minute, o scurtă prezentare, un mesaj din partea profesorului Basetti. Sper să fie tot în ordine.
Da, sigur.
Să nu iau prea mult timp. Da.
Avem
Cu
suficient.
plăcere, domnul profesor. Suntem alături de dumneavoastră și vă ascultăm.
Mulțumesc foarte mult.
Da.
Prezentarea o țin în limba engleză, nu? Suntem cu deschidere sau o țin în limba română? Cum facem?
Putem și, nu știu dacă sunt, domnul profesor Lisnic cunoaște, dacă sunt vorbitori care necesită engleza, fiindcă dacă nu, e mai accesibil în...
Dar cum spuneți, așa fac. Fiind poate mesajul...
Deci trebuie să întrebăm pe Helen, care este reprezentantul Academiei Europene, deoarece prezentarea respectivă va fi înregistrată și apoi plasată pe site. Adică s-ar putea și alți colegi din alte țări să vizualizeze această prezentare. Dați să întrebăm pe Helen, cum spune dumneavoastră. Helen, good morning. I'm Vitaly Lisnik, the local representative from the Moldovan Society of Neurologists. We are asking, the area from the countries, Romania and Moldova, which speak the same language. And Professor Mureșanu could present his presentation in both languages, in Romanian and English. For local, of course, participants, it will be better if he present in English or in Romanian, but if necessary to present in English, he could do this as well in English. Please let us know how to proceed in this situation. Or it's up to us.
Trebuie să decidem.
Cred că puteți prezenta și în română. E o limbă europeană.
Da, bun, știu, dar voi trebuie să-mi spuneți. Da.
Posibil pentru participanți ar fi interesant în limba română. Sigur că și domnul președinte, domnul profesor Lisnic, poate mai consult și vezi și ne zici. Dacă sunt, poate diapozitivele sunt în engleză, putem și în limba română. Vedeți cum.
Scriu dumneavoastră un mesaj și văd ce răspunde până atunci.
Da, ar fi bine ca să știm.
Eu văd că printre participanți este, de exemplu, Iulia Maier, scrie ea în... Asta precis că nu e moldoveancă.
Precis, da.
Da, dumneavoastră din partea Comitetului
Din partea
Educației.
IAN-ului.
Da.
Iulia Maier este din partea IAN-ului.
Ea a fost și în Chișinău.
Sigur că da.
Dar nu văd domnii profesori Capos și Bițdor.
Probabil că eu o să se logheze mai târziu.
Probabil atunci putem începe. Eu le-am transmis un mesaj și așteptăm răspunsul. Până atunci cred că ne vor spune. Începem, da?
Cam în cât timp intrăm atunci?
Începem.
În 15 minute.
Important să știu. Da.
În 15 minute. Dar acum începe welcome.
Da, începem welcome.
Începem într-un minut, vă rog.
Da, vă mulțumim. we can start, I think. Dear colleagues, dear ladies and gentlemen, good morning. I'm Vitaly Lisnik, representative of the Moldovan Society of Neurologists. The passion for neurology gathered us again for this wonderful event. It is already the 7th Congress of Neurologists from the Republic of Moldova. And before the Congress is organized the Day of the European Academy of Neurology. And this is already the second EAN Day in the Republic of Moldova. More than 300 neurologists from Moldova and from neighboring countries registered for this event. I'm thrilled to convey my warmest greetings and a heartfelt welcome to each of you who shares and respects this discipline, neurology and neuroscience. We are happy to inform you that the initiative of the Society of Neurologists to organize an European Academy of Neurology Day before the National Congress was welcomed and finally translated as the Day of the European Academy of Neurology. The first such day took place in Chisinau in 2017 within our national, the 6th Congress, and at that time the program was led by Professor Günther Teuschel, at that time the president of the European Academy of Neurology. And the organization of the day was supervised locally by the executive director of the EAN, Anya Sander, and the representative of the Educational Committee, Julia Meyer, who is also online today. Such an experience was welcomed, and only in this year, this day is organized already by the Hellenic, by the Armenian and Kazakhstan Neurological Association. Initially, the EAN Day had to take place in 2020, but of course it was postponed due to the epidemiological situation. But neither even the mighty COVID-19 pandemic nor our busy lives could stop us enjoying this important scientific and education event. So let me introduce our invited speakers and of course our great friend, Professor Daphne Mureșanu, who is the member of the board of the European Academy of Neurology. He is the chair of the European Academy of Neurology Education Committee, and at the same time he is the president of the European Federation of Neurorehabilitation Societies. It could take 15 minutes until I will let you know all the positions that he has, like corresponding member of the Romanian Academy, president of Society for Study of Neuroprotection and Neuroplasticity, and lots of others. And of course, we are happy to have such a friendly leading professor, and we organize many events together. We'll join Professor Ludwig Karpusch from Basel University, the leading specialist in the world in the field of multiple sclerosis neuroimmunology. Professor Alexander Bisdorf from Luxembourg. He's the president of the Luxembourg Neurological Society and is the chair of the Guillem's section and board of neurology. And of course, we welcome our local professors, Professor Stanislav Gropa, who is vice rector for scientific research of the Medical University Nicolae Timișoara, and Professor Mihai Gavrilyuk, chair department of neurology. I don't want to consume your very important time, and let me offer the speech to our distinguished guest, Professor Daphne Mureșanu. Nu vă auzim.
Microfonul, domnule.
Da, eu l-am fixat. Dear friends, ladies and gentlemen, I would like very much to thanks for this great opportunity. I can do my address in English, of course, because it's EAN Day, but I would like also to mention something in Romania. Dragi prieteni, este o mare, mare bucurie să fiu alături de voi. Sunteți poate cei mai apropiați dintre toți colegii vecini și în toți acești ani noi am fost extrem de, să spunem, împreună în toate proiectele noastre atât proiecte educaționale, proiecte științifice, cât și proiecte elaborate despre care voi mai face vorbire în intervenția mea. So I'll switch back to English now, mentioning that this is a great privilege, absolutely great privilege to be together, and always the Moldavian neurologists, Moldavian society, and Moldavian colleagues have been at the very heart of our cooperation. In respect to cooperation with Romania, but in respect particularly of cooperation with European structures, by and large with European Academy of Neurology, the development was tremendously active. We have to acknowledge that the Moldavian Republic is one of the few countries that developed an EAN special dedicated day so dynamically for the second time. I have a vivid memories from last time when we have done this together in a very successful way. I believe Moldavia is a very fertile soil for the development of science, for the development of special deep relations, and for getting to an outstanding level of neurological practice today and in the future. Thank you very much. And later on, further on, I will try to convey a very important message from our president, Professor Bassetti.
Thank you very much. We received the answers. The preferable language of your presentation should be English.
Great.
Romanian is exception, but English is preferential. So I don't know if Professor Ludwig Kaposch joined, but if maybe later, we invite for the welcome speech academician Stanislav Groba.
Onorată asistență, stimați colegi, dragă profesor Dafin Mureșanu, stimate domnule profesor președinte Lisnic, onorat profesor Gavriliuc, este un eveniment destul de important pentru noi toți, nu numai pentru neurologi, ci pentru medicii din Republica Moldova. Un astfel de eveniment la nivel european este distins și este extrem de necesar pentru noi, cei din Republica Moldova și nu numai. Deci, este o tematică destul de interesantă, actuală, necesară. Deci, va veni în suportul medicilor, atât din Republică, cât și peste hotare. Din partea Universității, conducerii Universității de Stat de Medicină și Farmacie Nicolae Tistimițanu, am onoarea să transmit mesajul de salut a domnului rector, profesor universitar Emil Ceban, cu urări de succes, de susținere și apreciere. În special, foarte mult prețuim poziția domnului profesor Dafin Mureșanu, care pe tot parcursul timpului ne-a sprijinit, este unul din cei mai apropiați prieteni și susținători ai Societății de Neurologie din Republica Moldova. Sperăm că prin intermediul domniei sale, în viitorul apropiat, vom avea și o mai mare apropiere de societatea atât europeană cât și cea din România. Dear colleague, let me greet all for you and thanks for your attending this extremely important meeting. Thanks to the organizer and especially Professor Mureșan, Professor Lisnic. Thank you very much and success.
Thank you very much, Mr. Professor Mihail Gavriliuc.
Good morning, ladies and gentlemen. Bună dimineața, doamnelor și domnilor. today is a day of neurology in all Republic of Moldova. I think in all Europe, why not in all world? Because all neurologists today will have a possibility to attend the selected presentation of distinguished professors as Dafin Mureșanu, as Ludwig Kapos, and as Alexander Bisdorf. I think these topics that are selected are very important for practice and for scientific research in our country. Why not? Because in a country that is in the east part of Europe is necessary now to select the special topics that will develop, especially the research, the possibility to understand and to use in practice the European special guides and protocols. This is weak point in our activity now. And I think the young doctors, the doctors with big practice, and especially the students will appreciate this possibility because the professors are selected not only the topics, I think they work hard to prepare this presentation. We thank them. In the same time, I thanks to the organizer, to Professor Lisnik as president, to academician Gropa as a university representative of Moldova. I think all this day today will be very interesting, and next Congress days not less. Thank you for your attention. Good luck for everybody and good results.
Thank you, Professor Gabrieluk. We welcome Professor Alexander Bisdorf from Luxembourg. We were sitting for more than 20 years close to each other at the the meetings of delegates of the European Academy of Neurology. He immediately agreed to come to our country and to present the European Academy of Neurology in Moldova. Unfortunately, it is online. But anyway, welcome, Alexander, and please, if you want to tell some welcome words.
So I hope everybody can hear me. So it's also a test of my connection, and does it work all right for you?
It's okay. It's okay.
It's okay. Well, it's also an honor for me. I must say that I would have preferred to be present with you and learn to know your country, because I didn't have yet the opportunity to travel to Moldavia. You have assembled a big program over 3 days. It will be, I think, very tiring for all the listeners to follow all that with high attention. I am happy that you invited me to talk on vertigo. It is an area which is, I think, largely neglected in most trainings, and I hope I will give you a contribution you will like and will be useful for your practice.
Thank you very much. We are looking forward for your presentation. And Professor Kapos, I was informed that he also is in connection. Professor Ludwig Kapos, well, a little bit later. Professor Dafin Mureșanu, would you like to present the welcome speech of the President of the European Academy of Neurology?
Yes, this will be a great pleasure. So I will just initiate the screen sharing now. Just let me know if you may see my screen. Is this okay? Can you see my screen?
Yes.
Yes, we see. We see.
Yes.
Okay, that is very nice. So this is absolutely a great pleasure to be with you, as I mentioned, and I would like to deliver this message, of course, for you all. But of course, I'm extremely happy to see this great team, Professor Lisnik, Professor Gropa, Professor Gavriliuk, putting together an unbelievable good program. And I believe that this is a great EAN day, and Professor Bazzetti would like to convey clear messages to you, and this is my mission to deliver at least some of them. We do hope that in the near future we'll get better chances, we'll have better chances for closer and more dynamical interaction, and of course to be with you in the beautiful and fantastic Chisinau and Moldova. Dear friends, care
Recording
along
in
the way.
progress.
And this is a dynamic development, and absolutely many advances have been done in this respect in the last year. Among the priorities that EAN has and will develop is, I would say, science is one of the most important, and this is materialized by Congress's substantial work with the guidelines. I'll come back to that. It's an important focus on the panel works and a lot of scientific fellowships generated. And of course, we have a high-end top-notch with our European Journal of Neurology. We have this year's priority with the COVID-19 registry. We have discussed this before. A great advance describing economic burden of neurological diseases, and also elaborating on value of treatment. And I would say that within this frame, the value of treatment study on sleep is one of the most dynamic ones. EAN Winter School will come soon, as winter is approaching. Just a few ideas regarding EAN neuro-COVID-19 research. Today, currently, more than 1,600 patients have been enrolled in 37 sites, 25 countries, 4 continents, and we have a great output for publications in this respect. EAN Congress, as I mentioned, is extremely important. We try to disseminate the important program and messages along many channels. We have a very interesting new TV channel. We have a live interactive session networking area. It's very active. We have simultaneous translations and sessions with other societies. I would say that this year we had a very, very interesting advocacy program. I hope you had the chance to be exposed to this. EAN guidelines are one of the most important priorities, and we have a new team there in the office. We have a strategic plan. We prioritize better. We have in-house capabilities currently, and we have a better methodological support. There are 7 new guidelines. We have a large number of guidelines in pipeline, and this is the moment to acknowledge that the contribution of Moldovan Republic towards one of the latest developed guidelines, the pharmacological support in early motor rehabilitation after acute ischemic stroke, was one of the most important one. And I would like with this occasion to thank a lot Professor Lisnik and Professor Gropa for the great contribution and the hard work for elaborating this. It was a long work, more than 3 years, but at the end of the day, we had a tremendous success. European Journal of Neurology, it's also a very important priority. We have a good submission rate. As you may see here, the impact factor went up to 6.1. We have a very rich area with video interviews, publication on special publication of named lectures, and we have special issue 2021. Education needs among priorities as well as a very strong pillar. And this is, I would say, generated and established during the Congress, during the schools. We have this cluster of fellowships. EAN is investing more and more in these grants, and we have now European curriculum, which is a living body developed all the time, as well as EAN e-learning platform, which is getting a very interesting and very useful tool. Membership is dynamic. We have the individual and corresponding members. We have fellows of EAN. Residents and research fellow section is developing. And students are now more with us. We have a gender and diversity task force, which is very active, and a mentorship program, which is really, really competitive. And I believe that soon will be I would say maybe one of the best in the world. We have as a priority for 2020, for the period 2020-2024, these advocacy activities. Of course, we try to improve the communication and relations with national and specialty societies, with international partners. We have a new office in Brussels. We have this excellent, fantastic program with One Neurology, making neurology a public health priority. And in this respect, we are collaborating with EFNA and many other, I would say, organizations. Brain health campaign, it's also our priority, and we'll do this further on in cooperation with WFN and WHO. Of course, brain health, it's at the very heart of the developments. We know that we have to create good awareness and to propagate these important messages regarding physical activity, mental activity, and good diet. This is the privilege also of Moldavian Republic to have a very good environment in this respect, to get enough sleep. And unfortunately, we are somehow in a difficult situation with the social interaction, but we have to promote it at any price. It doesn't matter how, we have to do something as we are doing today. We need at the end to protect our brain. We know that we have to take important aspects in consideration. I will not insist on brain health factors today because we know this. And I would rather list as a conclusion the EN 22-24 priorities. We are very much focusing, and we are really concerned to keep general neurology as an active body. We are focusing on pre-graduate curriculum, leadership program, and European Brain Health Campaign. I think this is an important message of Professor Bassetti and of the board, that we are actively developing this dimension, and we have, I would say, a group of very active scientists around us, and we very much consider the help of Moldavian Republic in this respect, as I mentioned. I hope that we'll have a very fruitful EAM day. I hope that further on the Congress will be successful. I hope that all the time we'll be together as we did in the past, and we always have in mind European Academy of Neurology. Thank you very much, and I'm looking forward for very fruitful and very wise, I would say, program, as always have been developed under your guidance. Thank you very much.
Thank you very much, Professor Mureșanu. Now we will switch to the program of the EAM Day, and it's our pleasure to invite again Professor Daphne Mureșanu to continue with the problem of stroke. He'll present the challenges and opportunities in stroke. Welcome, Professor Mureșanu, once again. Thank you.
I hope the registration it's there.
I didn't tell you that Professor Morishanov is also the chairman of the RO Neuro Institute for Neurological Research and Diagnostic. And together with Professor Borstein, they are organizing an excellent school, International School of Neurology Summer School. And this okay, we till now don't see. And these days, Professor Morishanov is organizing the RO Neuro Days, almost 1 week, teaching course in neurorehabilitation, as well as the International Summer School. And our young colleagues have the possibility to participate in this summer school. And some of Professor Gavriluk, academician Groppe, and myself will present lectures in the program of this summer school.
And biological reserve. I have to stress all the time. I will just have some small, I would say, links between that presentation and today. But have in mind always the level of the lesion and disability and the capacity of the system to recovery. So, how theory and basic research can improve this process, and it's very simple, as I told you. We have to pick up a relevant intervention that is relevant for the neurobiology of the brain, and then to go here into the evidence-based machine and to test it. So the message is that, you know, in the evidence-based machinery, we may test whatever we like. We may test even the paradigm that an apple a day keeps the doctor away. We may have a huge randomized double-blind controlled clinical trial testing that this is true or not. But actually what we have to test is relevant biological interventions that are fundamentally, let's say, useful. So in this respect, I will just repeat this sequence, pick up what is really knowledgeable and tested in basic research and experimental paradigm, then derive elementary rule, apply these rules to invent therapeutic procedures for individual use, and then to test it in the randomized control, typical good quality randomized control trial, or if this is not possible, or if we have any other hypothesis, we may use of comparative effectiveness based methodology, which is actually a non-interventional one. We discuss about that. When we have a control study, we may control. Basically, what we control is the heterogeneity of our data, and we have this inclusion-exclusion. When we have comparative effectiveness, a non-interventional, we don't have formal inclusion-exclusion, but we try to control this by any other means possible. By the way, we detect the confounders, we may stratify according to different rules and by different parameters the population in such a way that we compare like to like. So that would be the, let's say, the differences and I would say the similar aspects related to these two methodologies. Then the use of biomarkers it's extremely important, and it's strongly recommended, particularly after 2017, also by the dedicated advisory board, the World Federation of Neurorehabilitation. The central paradigm that we know today of brain recovery, actually post-lesional brain regulation, is that after any kind of lesion, we have a continuous defense response. We call it endogenous defense activities with two sequences: a short-term oriented mild sequence and a long-term oriented robust sequence. Short-term means hours and days maximum, which is very variable. It's very individual, this, as many other aspects are individual. For example, very personalized, like the persistence of penumbra, for example, after a certain focal ischemic process. And then the long-term oriented, which should be used. Actually, we don't have too much capacity of protection endogenously in our brain, but we have this consolidated process, as I mentioned, with these two entangled loops. Very important. One is the loop of protection, and the other one is the loop of recovery. Now, the key message is that whenever we have an active protection, we don't have the chance for a good recovery process or to upregulate this process. Only after the downregulation, the spontaneous normal downregulation of protection, we may go up with the system, will go up with the recovery process. So these two sequences we define today as being anti-correlated. And the anti-correlated principle governs the whole levels in the brain, all the aspects. Today we have learned a lot about the pathophysiological mechanism. I just want to make you familiar with these new changes. Today we look at the pathophysiological mechanism as being, not completely enemies, not only all the time deleterious, but also being normal processes that are in balance and should be rebalanced further on. This is a logic aspect. The anti-correlation has a deep biological sense, and only by understanding this and applying this, we'll be able to improve our strategies for recovery for the very simple reason, because I'll give you the simplest example. Here, we have to fight during the protection phase with glutamate effect, for example, but in the second sequence, which is robust, consistent, and long-term, we need a lot of glutamate. So therefore, artificially, or somehow by an external intervention, it's very difficult to keep this sequence. So what I also think that is important is to understand that this anti-correlation is everywhere in the brain, and we find this at all three levels of brain functioning levels: cellular, molecular level, circuitry level, and dynamic network level. And we know that for cellular and molecular level, the functional and structural unit of the brain, it's neurovascular unit. So the neurovascular unit is the real, I would say, hardware of the brain, because only at the neurovascular unit we may talk about these key aspects and properties of the brain function, actually nervous tissue, like blood flow regulation, blood-brain barrier exchange, immune activity, trophic support, hemostatic balance. So these functions are not functions of the neuron. Neuron alone cannot do that, only in the ensemble created in the frame of neurovascular unit. The components of neurovascular units are extremely well defined today. Basically, we have neuron endothelial cells and glial cells, but we have many other components here. I will not have time, just to give you an idea that different components of neurovascular unit have a very important role. Yeah, particularly in respect to blood-brain barrier stability, in respect to immune regulation, and all this machinery is functional because biological molecule, and these biological molecules are somehow functioning in a different way than chemical molecules. We may have, coming out of one single molecule, maybe 20, 30, 100 effects, depending on the way which this will be expressed functionally. Because a single molecule, think about a transcription factor may have many, many roles and many effects according to the activation of different parts of the molecule. And in the second next level of complexity, these molecules will interact together, generating different types of effects. So we'll call it this synergic effect. So actually in the brain, combination and proportion of different biological molecules have a certain particular well-described role, not only one. So if we test one single molecule in a dish, the effects, this will not be relevant to the effects of that molecule in the brain. So we have to look at the whole biology and whole ensemble. That's why such a complex ensemble of molecules will generate the same molecules, but in different proportion will generate different effects. The sequence of protection, but the same molecules in a different proportion will generate recovery. And please contemplate the idea of anticorrelation. Look the story of the glutamate. Under normal circumstances, glutamate on pro-survivin pathway will generate by synaptic activity good effect, plasticity, but working on extrasynaptic pathway will create cell death. So actually we have to look at the balance. These two pathways cannot be activated at the same time. When one is active, the other one is silent. So the principle of anticorrelation governs the cellular molecular level based on these aspects. So we may see and express this very nicely if we look at the effect of biological molecules in the brain. Look at the trophic factors. A pro-neurotrophic factors working with this ensemble of receptors will generate cell death whenever is necessary. The other one will generate, when this molecule will be activated, will have an active neurotrophic factor, for example, generating cell survival. So also this balance is activation and deactivation is controlled by a complex system. Usually the most active and important system is the system of furins, enzymes that produce this split of the molecule and activated a certain molecule. Now, we have to understand that we have very active processes contributing to the restorative mechanism at the cellular molecular level. I will just mention briefly. We have vascular remodeling and angiogenesis process. We have neurogenesis, which is all the time active, but ischemic process, ischemia, focal ischemia, very important to understand that we are talking about focal ischemia. Focal ischemia will generate activation of neurogenesis. We have very well demonstrated areas in which neurogenesis is activated. Subventricular zone, subgranular zone are the most important. They are generating different types of progenitor cells with different outcome. Newly formed cells from the area of lateral ventricle will generate GABAergic interneurons, which are very important because this will be incorporated in the default mode network. We'll see later on. And the subgranular zone will generate neurons that will be let's say, directed towards other different targets. Axonal and dendritic remodeling, it's an important factor, and this dendritic sprouting, it's present all over the brain, not only in the lesion area, not only ipsilateral, but also in the contralateral hemisphere, but also down in the spinal cord, trying to balance, to readapt the whole system according to the paradigm of neurorestoration. I will come back to that. Of course, we may have agents that may amplify this process, but the key message is that stroke impacts the whole brain, and the whole brain will react. Oligodendrogenesis, it's an important factor, and this will contribute to, I would say, to control the brain atrophy, which is very much prone during after the process is initiated by stroke. We have a high activity of blocking the blockers, because naturally the plasticity is blocked by some molecules, and these molecules, which are different types, different classes, but usually they are glycoproteins, they are blocking plasticity, because we know that plasticity is not only a positive phenomenon. When we have an excess of plasticity, we'll have the chance for many disorders, starting with epilepsy, ending with the tinnitus, for example. All these pathological conditions are based on pathological plasticity. So excessive plasticity should be controlled and blocked. And the highest level of inhibition of plasticity is in the spinal cord, because the spinal cord is a more executive organ, not in the sense of executive function or dysfunction, but in the sense of executing the orders coming from the brain. So should not think too much. We are thinking with the brain, not with the spinal cord. This is just a consideration. At the circuitry level, we have the process of plasticity, which is extremely, extremely important and intense, as long as it's normal and is not in balance. And plasticity is defined as the capacity of the brain, the intrinsic capacity to change existing structure, function, and connection in response to external stimuli, or, the environmental, learning, new aspects, or after an injury. And it's also the mechanism by which we create a transition from early learning to automatic responding. Then we have this circuitries, particularly the corticobasal circuitries. I will not insist. I just want to keep you active with the idea of anticorrelation, because we have a lot of plasticity, especially during the process of active learning, when we have here a lot of voluntary, I would say, driven activities. And after we learn in this circuitry, we create a transfer by normal plasticity here into the sensory motor network, which is the substrate of automatic behavior, because always we talk about behavior, not only behavior. It's more complex. It's not just described our motor activity, as was mentioned. It's the whole cognitive. Of course, also here, if we have an excess of plasticity, we may create tremendous, difficult, controllable disturbances like impulse control disorder. This is the loop. Hyperactivation of this may create problems. So just want to keep the track with you and remember the anticorrelation at the cellular molecular level everywhere in each pathophysiological processes: excitotoxicity, inflammation, good part, bad part, apoptosis, good part, bad part, because always a pathophysiological mechanism, it's an imbalance in something useful and normal for the brain. Here, what we have an acceleration or a deceleration or blocking plasticity, a process of stimulating or blocking plasticity in a very wise way, because this balance is crucial. and will create the prerequisites for our adaptive behavior, which is very much modulated by dopamine. Then keep in mind that this balance between accelerating and blocking plasticity is also anti-correlated, because we cannot accelerate and brake at the same time. Of course, we may do this, but then the system will be destroyed somehow. Now, at the highest level, we have the connectome, we have the large-scale networks that function. I will not insist that there is a permanent pulsation between cortical segregation and integration. Modules should work separately in the brain, but then they should communicate and exchange information between the visual part, how the visual activity will be integrated into the cognitive, extremely complex context. And all these areas, all these modules, they work together and they exchange information. It is a continuous process of segregation and integration. And this is like a pulsation of all these fantastic, well-regulated networks. But here we have also the principle of anti-correlation, how salience network will do the switch between our inner activity of the brain, supported by default mode network, and our, I would say, external related task-oriented driven activities. So we may not have an activation of the default mode network and the central executive network as a whole. There are some parts that are concomitantly activated, but as a systems, as a big part of the system, they cannot work. And one of the characteristics of features of impairment, this is valid also for vascular cognitive impairment, but mostly for the generative processes, it's the incapacity of the default mode network to be deactivated due to a deficit of GABAergic regulation. So you see that anti-correlation is also here. I will not insist, you know, this principle of anti-correlation is very much visible when we have the attention network, the two networks, dorsal and ventral, and one is goal-oriented, the other one is stimulus-driven. Whenever we have to focus our attention, we have to work on the goal-oriented way. And when this focus attention will be interrupted, this will be because we have this network which is automatically functioning and interrupting whenever necessary the process of attention. So the bottom line, and this is, I would say, the end of the first part of my presentation, talking about the concept of anti-correlation, which dominates the activity at the cellular molecular level, at the network level, and also at the large-scale network level, based on integration and segregation of this dynamic network picture of the brain. These three levels, of course, they are also correlated between them, because whenever we have an activation of a function at the networks level, this will go down immediately because they need a support coming from the genes and from the cellular molecular activity. And today we know that this overlap completely. Whenever we have an activation of function, we have an activation of the hardware of the brain, of the machinery down at the cellular molecular level. And this correlation is reflected by neurovascular coupling, which actually correlates the activity with the blood flow. And we can measure this by functional MRI, Bolt signaling evaluation. And today we define it, and maybe I will come back if I will have some time, just to mention that today it's more and more used as a surrogate marker for as a biomarker, let's say, for development of the cognitive impairment. This will evaluate the risk of further cognitive impairment, because whenever we have a hemodynamic lag, and the longer is hemodynamic lag, the higher is the risk for vascular cognitive impairment. And we have some very good data proving this. So this hemodynamic lag is associated with the risk of developing this executive function. Now, it's very important to treat the lesion. It's very important to create recanalization. It's very important, even more important, to have this reperfusion, the microcirculation in stroke, and a very high impact and extremely relevant concept related to that. This is important. But when we're talking about brain recovery, we have to understand that this is an important asset, that the concept of restoration is actually based on the idea that the whole brain will react. This is not just and only lesion oriented, is not perfusion limited. We know that all neurorestorative treatment, because I told you the second sequence of the endogenous defense mechanism, it's long, it's robust, and it's very sustainable one, and is not restricted to the first hours, and can be performed with extended time window. And CNS, it's extremely primed for neurological recovery. And of course, we may do more in the future based on that. And we have different pharmacological and non-pharmacological, I would say, intervention that may enhance a bit this consistent and long-term oriented process. Restorative treatment should act synergically. That is very important. So therefore, if you have a molecule which is blocking glutamate or blocking the plasticity, and you have seen he described a list of deleterious substances that are blocking plasticity. So those substances, if possible, should be avoided, because they will automatically block the process of plasticity, which is the substrate of recovery. So therefore, we should be knowledgeable. What molecules are we using? So to put it in a different way, first of all, it's important to know what should not use, and then try to integrate this. We know that we have a high range of spontaneous recovery, and rehabilitation is primarily delivered in this period, which is around 3 months. Spontaneous recovery, most active part of spontaneous recovery post-stroke is the first 3 months. But we can a little bit broader this window. We can enlarge it by different interventions supporting the endogenous machinery of brain functions in the way the brain does. That is important. Combining, exactly trying to keep the ensemble of the two loops that we have described. So therefore, talking about pharmacological intervention, we may be alert to the fact that today we have the tendency to change the old classification in protectants and neuroactivators. Today we are talking about those molecules that are able to support the underlying mechanism of brain, namely to do as brain does. Because doesn't matter what intervention we'll use, pharmacological, non-pharmacological, at the end of the day, if you do not have the biological reserve, and how can we translate this biological reserve? We may evaluate this by different means. I will not come back. But as long as you have reserve, you have a function, and you have this endogenous machinery. Brain has a limited repertoire to react after a lesion. It's the same way. So therefore, if you have reserve, any intervention will have effect based on that mechanism. Not intervention totally floating in the vacuum will create something. So we have to see the interaction between intervention and machine, endogenous biological machine. If we don't have the machine, any intervention will not be useful. So this is another important aspect. That's why we need to evaluate the capacity of the patient. Of course, we have to rethink the whole recovery and the whole science of neurorehabilitation based on totally different paradigms. After understanding the complexity of brain function, after understanding the connectome, today we know that the recovery, it's more about all the networks that are connected to the site of the lesion and how this network will work back the process, the normality will bring back the function. So it's a lot about the connectivity, it's about the connectome. And there are different paradigms. We have different deficits, particularly when we talk about cognitive rehab, which is fantastically important for rehabilitation. We talk about different mechanisms. In TBI, we have a certain type of cognitive deficit, and you may see it by functional MRI. The modules are very active in the TBI cognitive impaired patients. We have a problem with connectivity. In Alzheimer's disease, for example, or neurodegenerative, whatever, we have a problem with the modules. The activity of the modules is reduced, despite the fact that connectivity will be active longer time. So only by understanding these important aspects related to the neurobiology, only by this way we'll be able to choose the right paradigm. So therefore, I like very much this statement of Maurizio Corbetta telling that indeed, if we want to create further paradigm for neurorecovery, we should understand the neuroscience. And then we'll be able to differentiate between different disorders, different mechanisms, different aspects. Look how complex is the connectome. Look at the normal brain, a normal connectivity in a normal person. It's rather stable. It's also it's stable for the patient, but it will be different between different individuals because we are different. This is clear. But if we have three approximately clinical phenotypically patients with the same clinical picture, if we'll go down into the connectomic, you will see that, for example, patient number 1 will have this geometry, patient number 2 will have this, patient number 3 will have that. What does it mean? We have different types of dysfunctions, of deficits. So we have to approach this in a knowledgeable way. That would be the idea. Now, currently, we are able to understand the brain damage and repair better. We are able to understand the pathogenesis of neurological disorder. Actually, what we have today, as a real, I would say, general conclusion, bottom line, let's say, we have two models based on this complexity. So any imbalance in anticorrelated processes could generate disorders on two types of models, top-down and bottom-up. The bottom-up model is the classic way of describing and trying to understand by a very materialistic way the development of disorders. So we have etiological agents, biological, chemical, physical, etiological agents acting at the cellular molecular level, disturbing cellular molecular level, which is the hardware of the brain. At this level, there is no upload of human behavioral programs. It's just the hardware. But disturbing the hardware will disturb the circuitry level, and the circuitry level will disturb the network level. And if we have this sequence, cellular circuitry network, at the end of the day, we'll have a global sufferance. The other way around, today we know, and we know very well, and Professor Bornstein really did it nicely, and we like very much the Tabasco concept and the idea that stress per se may induce changes. And this matches very nicely the reality, because neuropsychological agents, namely stress, whatever will be the definition, may disturb the network level, the balance within this complexity of connectome, and this will disturb the circuitry, and at the end, this will be incorporated at the cellular molecular level. And today we have to accept also this model. So therefore, we have to contemplate from these two ends, these two models, bottom-up and top-down model. Now, regarding stroke, and coming to the added value of neurorehab in stroke recovery, understanding these basic aspects, I think we have a better opening for practical related approaches. Today, we know that with the help of acute treatment, using the capacity and power of stroke units, using the whole secondary stroke prevention mechanism, we'll be able to get an important success in treating our patient. Actually, if we'll be very brief, we'll say that just the use of stroke units, aspirin, and thrombolysis will have, if we count at 1,000 stroke patients treated by this, altogether in the setting of a stroke unit, we may say 131 lives. Yes, lives and disabilities out of 100,000 stroke patients. Out of 1,000 stroke treated patients. And you see that the magnitude of intervention, the effect of just by treating the patient in a stroke unit and thrombolysis, it's almost, it's a difference, of course, but we may say that, we are not very far. So that's why it's so important to treat neurological patient in the right place, by the right team, by the right persons. And this is, of course, the place is the stroke unit, and of course, the neurological guided team should be there. If we add all the interventions related to secondary stroke prevention, we'll be able also to avoid 225 out of 1,000 stroke treated. And if we add these two numbers, we'll end up with having more than 1 of 3 strokes treated. And these are Professor Brining report. This is the Professor Brining report, and you may understand that the numbers are even better today because I didn't upgrade them, but the numbers are even better because we should add in top of it the effect of thrombectomy. Unfortunately, we cannot do it on the large scale, but we are better and better. Now, this is the added value of treatment in the acute phase and incorporating all secondary stroke prevention. So it's a lot. If we'll be able to add in top of this neurorehab intervention, then we'll get much more. So today we describe the recovery phase post-stroke as being hyperacute in 24 hours, acute up to 7 days, early subacute 3 months, late subacute up to 6, and chronic after 6 months. And the issue always is when to start rehab. We are pedaling on some ideas which are, very simple, as long as you keep the clinical common sense and you have the experience of the clinical practice. Actually, the timing, it's not so, only if we like to have an evaluation based on really strict evidence-based parameters, you may have some dilemmas. But, mobilization rehab should be initiated only when the patient is stable biologically. And this may be very personalized, let's say, according to different, clinical patient conditions, according to his real status. But of course, evidence-based is very useful. And we may get a good orientation in this respect, as long as we'll use wisely the methodology. And if you look into the guidelines for adult stroke rehab and recovery, 2016, which is part from the large frame of AHA guidelines, we will see that the high dose, very early mobilization within 24 hours can reduce the odds of favorable outcome at 90 days. And this is a general statement. This is not valid for everyone. So you should think, we have our clinical experience, we have the brain with us to think always. This should not be applied to everyone. Okay? Maybe some patients will not be able to face recovery, not even after 1 week. This is a general recommendation that should be taken cautiously, wisely, and, should match the reality of the individual patient. Now, biomarkers are important. I will not come back to biomarkers because I have presented that. This is just a summary. What I would like to underline, to highlight again, is that we had a completely orphan territory in creating biomarkers for cognitive recovery. And this is now we may use the hemodynamic lag, which is extremely important. And based on this technology, neurotechnology of the functional MRI connectivity, but we may measure the connectivity and we may assess connectivity also by EEG and some other sophisticated intervention like magnetography, and defining many parameters. Today we are able, by assessing the connectivity and detecting the patterns of connectivity, to differentiate between those who will develop the cognitive impairment and between those who will not develop the cognitive impairment and will stay as mild cognitive impairment. So, briefly speaking, if we have a mild cognitive patients, how can we predict as a biomarker that this will develop dementia? No way by any cognitive test, by any kind of evaluation, but functional connectivity, which describes exactly the blueprint of the connectivity of the patient at risk. So it was defined the concept of stable patient or stable matrix and converter matrix. So these correlation matrix are very nicely defining the future perspective of patients, and we have a nicely integrated data now. And I think if we'll carry on with this message, we'll be able to add something in top of further development. And I will stop here, and I would like to, thanks for the kind attention.
Thank you very much, Professor Morishano, for your lecture. It was very interesting. It was on the border between fundamental science and neurology and other disciplines. It is very important for our young specialists, neurologists, to be involved in research and to understand better the background of different problems, pathological problems, and the mechanism of neuroplasticity which happens in case of a problem. Thank you very much. And now we are looking for the second presentation. If Professor Ludwig Kaposch is available. He was able to connect. Not yet. Professor Alexander, could you help us
Yes,
in
and
this situation?
I step in. No, I'm happy to step in. Let me just.
Excuse me. I will present you once again. Professor Alexander Witzdorf is a well-known specialist in neurology. He is the president of the Society of Neurologists from this small country, Luxembourg. This is a small country. It has a lot of possibilities to perform education and research. Professor Alexander Witzdorf is the chair of the WIEMS Union European Medicine Specialties Section and Board of Neurology. He was responsible for the board examination in neurology, and a lot of young doctors passed this exam and received the degree, the European diploma in neurology. As well, he's a well-known specialist in the field of this very narrow field, but very important about vertigo. All of us has these patients, but it's very difficult sometimes to approach these patients. And I think after the presentation given by Professor Alexander Witzdorf, this will be rather easier for everybody, not only for him. Welcome, Professor Witzdorf.
I have unmuted myself, so is that again okay? Now
Okay.
I lost my presentation again. There it is. Can you see my presentation?
At this moment, we see you.
Okay. Because to my end, I think I share it, or is it something the operator needs to change? Otherwise, I try to share it again. See. Can you see it now?
Yes, we see it.
Okay. Well, thank you very much, Vitaly, for the invitation to give this talk. You were saying that it would be easier afterwards. I hope it will be easier. I know that the topic is complex, but anything in neurology is complex, I think. We just don't, we are more familiar with one or the other topics. So I try to give you an overview of a few selected topics. So let me see if that works here. Okay, so I want first to give you some information of the basics of vestibular system, and then also make you aware of the very complex consequences dysfunctions of the vestibular system have. Then give you some tips on how to take history, some comments on clinical assessment, and then I give you a presentation of the selection of vestibular disorders. Some I do this morning, and some I will do this afternoon in the workshop. And then I'll also address something important, like popular myths about vestibular disorders. So you need to be aware that we are talking here about the system. It is not just an inner ear, obviously, because we get information of various sources which give the brain information of how we are oriented in space and how our body is oriented, how our body is moving, and how our environment is moving. So we get information partially from the inner ear, obviously, from the vision, but also proprioception and skin and touch. And this kind of information needs to be integrated and understood, because some of the information is not unambiguous. Because you might, for example, in a train, your inner ear doesn't, when you travel in a train, your inner ear doesn't tell you that you move, but you see it only. and you need to and your brain needs to obviously to understand that, and then design a motor program, and your motor execution will again change how you move. So, and that needs to be taken in a control loop. There is a particular challenge about the vestibular sensation, and that is also something which impacts how we take history in patients. And that is that this sensation of the labyrinth, which gives us information about the position and the movement of the head, is in complete unconscious. If you really think about it, you have no feeling, conscious feeling that that happens in your ear, whereas we have some conscious experience, obviously, of vision, smell, hearing, and touch. And this unconsciousness about the vestibular inputs not only applies to the inner ear, but also applies to the vision and the proprioception, as far as it is related to balance. And now, if we wonder if you don't have any conscious feeling, symptoms will only arise when there is a problem. And then they will also be difficult to feel where it comes from, or it is basically impossible to feel where it comes from. So symptoms can come if there's a dysfunction of the inner ear, the vestibulum, the vestibular nerve. There can be sensory mismatch between inner ear vision and proprioception, which the brain cannot resolve. That is also a source of potential source of vestibular symptoms. And the brain can be dysfunctional or misinterpret things. And that can sometimes be due simply through anxiety or obviously through structural lesions as well. And the consequences of disturbances of any kind can be of different natures. So we can have perceptual, so that you feel a movement where there is no movement, or you can feel disoriented in space or lost in space. That can have motor consequences, obviously, change of eye movements, change of postural position, your gait, how stable you are on your feet. It has very often emotional consequences, which is the loss of sense of control, of threat resulting fear, and cognitive consequences, which are derealization and depersonalization, because the construction of you in space is something which is done in the brain all the time. And dysfunction can lead to things like feeling out of your body or feeling strange in your environment. These people are not necessarily crazy. They could have a vestibular problem. When we talk about vestibular symptoms, we have four key vestibular symptoms, which are vertigo, dizziness, but also some vestibular visual symptoms, and the postural symptom, which is unsteadiness. Vertigo is defined by the illusion of self-motion, which is not really happening. That can be rotatory, but it can also be non-rotatory, spinning or non-spinning. There can be all sorts of movement, and they can also combine in a particular patient. And it is when you feel that your body is doing this movement. Whereas dizziness is a feeling that you are somewhere disoriented in space, but you cannot really feel a movement. This distinction is not done in all languages. In English, it's done. In French, for example, it is not really clearly done, and in some other languages as well. I don't know how it is in your language you're speaking daily. These symptoms can just pop up spontaneously, or they can be triggered by different things like change of position, motion of the head, visual input, sounds, and sometimes other things. I want to go into the vestibular visual symptoms, because it is also that you should be aware that not all visual disturbances arise from the eye or from the occipital area in the brain, or the optical nerve. They can also have vestibular reasons. One symptom is, for example, oscillopsia, which is a feeling that the visual surround is bouncing. That can happen if you move your head and your vestibular ocular reflex doesn't stabilize properly the images you see on your retina, then you can have the impression that the environment is bouncing, or the vision blurs. That is what is called here the head motion induced blur. So when you move your head, the vision is not clear. Once you stop, it gets clear. Visual lag is a symptom when you move your head and people have the impression that the images follow. So patients do tell you sometimes this. And then we call external vertigo when you see the surrounding moving. So when things are spinning around you. Visual tilt is a rare symptom. That's what you can, sometimes people see the whole world tilted by 90 degrees or sometimes really upside down. These are always central problems. Now, some aspects of history taking. How important is it and how shall we do it? Shall we do it, but what do you mean by vertigo? That is presently is it usual teaching. Well, I am busy in the Parani Society, which is a multidisciplinary society, and we developed these definitions of vestibular disorders. And here is a selection of disorders which have been defined. On the left side, you have a few where in the definition there is no single test. Sometimes tests are necessary for exclusion, but in the definition itself, there is no test. So it's only history taking. So you can imagine history taking is very important. On the right-hand side, there is a range of diseases where there are tests which are required in the definition. In Meniere's disease, it is not a vestibular test, by the way, a hearing test. And then when you have a loss of function of the both ears or one ear, then you need obviously measures to prove that. In vertigo due to orthostatic hypertension, you need to measure blood pressure, obviously. Presbyvestibulopathy, which is a partial decline of the inner ear and makes then symptoms in older patients when it would not do that in younger patients. You also need to measure that. And superior canal dehiscence is a rarer disorder, which is a bit special for the ENT doctors. Now, this is the classical way of approaching. And the classical way of approaching is to have the idea that the quality of the symptom is really important to guide you to the cause. And that is, has been promoted, it goes back into the 80s and 70s, so that when you say it turns, it's spinning, then it is inner ear. If it is presyncopal, then you are in cardiology. When it is disequilibrium, it's neurology. And when it is dizziness, well, then it can be psychiatric, metabolic, and so on. And that is simply not true because these, all these symptoms are not specific. They can occur in a very range of diseases, and they don't help to guide you a diagnosis with reliability, and also they don't help you to distinguish dangerous and non-dangerous causes. That's why I would encourage you to go for another system, and that we will talk about soon. And that is really important because the teaching also still by many ENT doctors is when it spins, its ear cannot be something else. That is simply not true, because spinning obviously can come about through inner ear problems, but it can also come through brainstem and cerebellar problems, even sometimes supratentorial structures. Cardiovascular disease, so orthostatic hypotension can well make spinning vertigo. It does more often non-spinning or vertigo or just dizziness, but it can make spinning. Psychiatric disorders also on the whole don't make spinning, but they may. And even side effects of drugs can make spinning vertigo. But all these diseases can also make dizziness. So it doesn't help you really to go through, to distinguish that so strictly. And in reality, most patients will have a combination of all of it. And so we recommend to start your history taking by trying to classify according to time into one of these three categories: acute, episodic, and chronic. And acute is a rapid onset of a sustained sustained means many hours at least of strong vertigo, dizziness, or unsteadiness. So it can be a combination of that or just one or the other, with features suggestive of new ongoing vestibular system dysfunction that can be vomiting, nystagmus, and severe instability. In the episodic, that is there in attacks, but there are good moments in between. That is very important to establish, because patients will not come up with that always spontaneously. And then you have chronic vestibular syndrome. Then the symptoms are always there. Always does not mean that spinning is going on all the time, because that is actually quite rare. But it can mean that every time you move, something is wrong. Whereas in an episodic form, there are moments you can move fine, and there are others where you can't. And this distinction is important to establish, because when you ask a patient, how does your vertigo come about? We say, when I move my head, or when I turn in bed, or when I watch crowds, etc., I get dizzy. Obviously, you need to dig in a bit more precisely of the symptom, but the next question to ask is, will it happen each time you do this or not? Or you have to ask, do you have good moments? Have you got moments where you can do all this and it is all fine? And if the answer is yes, there are good moments, and we know that we are in an episodic vestibular syndrome, and that changes the differential diagnosis to consider. Because if the answer is yes, every time I go out to watch crowd, when I'm in many people, or every time I move my head, or every time I lie down, I have it, then it is much more likely that there is a structural lesion which does a deficit and makes a symptom. When the answer is no, we are in an episodic disorder, and there it is much less likely that there is a structural lesion behind it, by the way. And it is also important for another reason. That is, we are testing people, and the appointments for testing cannot be given according to the presence or absence of a symptom. So often patients are there, and they will be tested at the moment where they are fine. And when the examination then is fine, don't overinterpret that, because it could be different when you do that in a moment where the symptoms are there or can be triggered. I personally, and I encourage that to everybody, always document if the test has been done in the moment of symptoms or in the absence of symptoms, because interpretation cannot be the same. Here is now a list of differential diagnoses for acute vestibular syndrome. It's not exhaustive, there are always some more. Obviously, vestibular neuritis, that you're probably all a bit familiar with. Labyrinthitis is the same, plus hearing loss. Stroke, which affects central or peripheral structures. You can have a stroke in your inner ear, you can have a stroke in this brainstem or cerebellum. When you fall in your head, you can get a concussion of the inner ear and also other structures, which can make an acute syndrome. Demyelinating disease, when they are happening in the brainstem, can have vestibular neuritis-like symptoms. Intoxications can do that. Sometimes abrupt discontinuation of antidepressants can make an acute vestibular syndrome, some intoxications, and also Wernicke syndrome. And then we have here the episodic vestibular syndrome. And I put there on the top vestibular migraine, because that is a disease every neurologist should get familiar with. And number two is benign positional vertigo. I think also every neurologist should be familiar with. And then there are more rarer things, like Meniere's disease that you have heard, vestibular paroxysmia, I will present a little bit later. Then it can be TIAs, obviously, orthostatic hypotension, cardiac arrhythmia, panic attacks, motion sickness disorder. That is when you get sick every time you travel, and medication side effect. And this vestibular syndrome is the most common. So that's why it is so important to establish, are we in this range of differential diagnosis, or are we in the chronic ones, which are when you lose your function of your inner ear on one or both sides, or when you have keep a sequelae after a stroke, or you have cerebellar degeneration or tumors. But there is also an interface with psychiatry and behavior, which can make chronic symptoms. I also will go into that in a moment. Now, I will present you a few things. In this presentation, I will talk about vestibular migraine, vestibular paroxysmia, mal de débarquement syndrome, and triple PD. And this afternoon on the vestibular neuritis, vestibular bilateral vestibulopathy, and PPPV. And let's dive in. So we go into the migraine and vertigo. Now, up to today, in the headache world, it is still sometimes a controversial topic to accept this vestibular migraine story. But if you look at even the classification of headache disorders, which has existed for more than 20 years, vertigo has been in the migraine area, recognized as paroxysmal vertigo of childhood, or in the brainstem migraine, which was told before basilar type migraine. So that migraine can make vertigo, even tinnitus, is actually not controversial. And when you look at how many patients have during migraine attacks vestibular symptoms, according to the series, it is actually quite high. So in fact, the principle that migraine can make vertigo is actually quite accepted, and it is very clear, I think, to most people. But what is more controversial is how far does the spectrum reach? So if you have people with episodic vertigo who have no headache or other migraine symptoms at the same moment, can that be migraine? And that is what it is about. And I think most experts nowadays agree that that is the case. The definition, the present-day definition, was published in 2012. For the vestibular expert, it's very clear, and for the headache expert, it was then still at the appendix of the classification. And so it has to be an episodic vestibular syndrome of a certain range of duration, 5 minutes to 72 hours, at least an analogy to the headache. And you should be a person who has migraine headache. Either it started together with the vertigo episodes, or what is more general the case, the headache has been there many, many years, and later in your life you develop vertigo as well. And then you request that at least at some proportion of these vertigo symptoms, other migraine symptoms are also present. And that can be headache with characteristics of migraine. It can be photo and phonophobia or visual aura. And you obviously need to be careful that it cannot be something else. Sometimes it is important to distinguish it from orthostatic or from TIAs. And if you take a strict definition like that, where most attacks will be accompanied by other migraine symptoms, that is in practice not the most common one. The most common one is that most attacks are actually independent of the headache. And that makes it then more difficult to make the link. And that is when you have a patient with a clearly established episodic vestibular disorder and who has not developed any hearing problem, you have to dig in his past if he has migraine. And many patients ignore that they had migraine when they were younger, or they have headaches and they don't know that it corresponds to migraine. And that helps you then to make the link, at least in the very probable basis. So the reality is vestibular symptoms often occur outside headaches. And then there's another challenge, that is the vestibular symptoms have no specific features. You know, when you have isolated aura, that is a symptom which doesn't hardly exist in any other disease, maybe in some rare manifestations of a TIA or a rare manifestation of epilepsy, but even that is, I think, a bit controversial. But visual aura is quite specific. Some aesthetic manifestations, like when you have a tingling which marches from your hand to your face within minutes, that is also something quite specific for migraine, but the vestibular symptoms have nothing specific like that. So when you hear them, you cannot tell this is more likely migraine, this is more likely something else. That makes it more difficult. There is something which can be helpful, that is that in a patient, the spectrum of symptoms is often large. They have short attacks, long attacks, they can have spontaneous vertigo, they can have positional vertigo, they can have just head motion vertigo, so only when they move. Then they have other moments when they can move fine. Then they have moments where they have visual induced vertigo, then other moments where that is not the case, and then they have other vertigos as well. So if you have a range of vestibular symptoms which occur episodically, that is very likely to be migraine. Okay, vestibular paroxysmia. That is attacks of vertigo, which are very short. Short means less than a minute, often just a few seconds. And it is one of these diseases which can repeat itself many times. That's why you have in the definition that you have at least 10 attacks. There are patients who have 10 a day, every day, over weeks or months. Some have it more rarely, but on the whole, it is a disease which high frequency of attacks. They always have the same phenomenology, so they are sometimes stronger, sometimes not so strong. And they on the whole respond to carbamazepine. And I will now try to play a video. I don't know if it will work. We'll see. This is a brave, hold on, I go back. This is a brave patient who managed to film himself during an attack. I don't know if the nystagmus comes across well.
Yes, we see it very well.
You see it, yeah. So you see a left beating nystagmus in this patient. And obviously he catched the first attack. He has been used to having that many times a day, and I asked him to film it because it's not necessarily there when you see him in your clinic. And now you see already it starts to fade away. And I'm finished. So that was an attack of vestibular paroxysmia. And that person then responded very well to carbamazepine. So this disease is considered to be a vestibular equivalent of trigeminal neuralgia. So that makes there are discharges in the vestibular nerve. Some people haven't thought that vascular cross compression is very common in that, but that is often not the case. And what is also strange, that is rarely accompanied by a hearing symptom. So if you see somebody now with a left beating nystagmus during the attack, we will probably presume it's the left ear because it is an excitatory nystagmus. But some have tinnitus, which goes with it, which is like a typewriter tinnitus. We say in their ear when they have the attack. And then it also goes away when they take the carbamazepine. Imaging may show abnormalities, sometimes also a little tumor lying to that, but on the whole, imaging does not contribute that much to the diagnosis. It's really a clinical diagnosis. And that's also why imaging is not part of the definition. But it is something which is, when you have a patient like that and you can treat him with carbamazepine, and within the days, the symptoms he had for weeks or months are suddenly gone, you will have somebody very grateful. Then I want to discuss with you triple PD. Now that is a terrible name, but that was a compromise to find that name to try to describe it a bit more phenomenologically. Precursor terms were phobic postural vertigo, which has been developed by the group in Munich by Thomas Brandt, an American group who called it space and motion discomfort, another American group chronic subjective dizziness. And that is an interface between neurology, psychiatry, and ear diseases. And that is a condition, is chronic vestibular disorder. So people have symptoms most of the time. And there's usually more dizziness and a non-spinning vertigo. So they feel like themselves like swaying from side to side. Or, it is present all the time, but it gets worse when they move. And it gets worse when they move in a particular way. That is, it is not always directly in the first movement there, but when they keep on moving a lot, it builds up. And then it comes to a moment where the dizziness is so strong that they need to stop. And when they stop, it also takes again half an hour, sometimes more, to go back to the baseline symptom. It is worse when you stand and when you lie, but that's very unspecific. But it also, the symptoms get worse not only when they do movement, but also when they see movement. So these are patients who have visual vertigo, and the consequences is that some activities are really difficult for them, like going to supermarkets or sometimes driving when there's a lot of traffic, or driving fast on the motorway, or going to a crowded place. And also when they read, the eyes get more quickly tired. That is also a symptom they also often have. And the disorder usually doesn't start just like that, but they have the vertigo of some cause before. And that can be a trauma, that can be a vestibular migraine, it can be a BPV, it can be a vestibular neuritis, which triggers these off and then develops into this. Now, what is the understanding of that? It is, we presume that something happens in the brain of these people, that when you have a vestibular triggered symptom, like let's say a neuritis, then obviously you are very sick at the beginning, and then you recover slowly, and then you need to start moving again, and you need to be careful in the beginning, and then you get better with time. But people are not experiencing that in the same way. Some will be terrified to die, others will take it much easier, others will mobilize relatively easy, others need a lot of encouragement to do that. And on the whole, those who have been very scared and who are very scared of moving and provoking the symptom, they are more likely to develop into triple PD. Also, people who are more anxious by constitution have a higher risk to develop it, but not all do. So it is an overlap, but it's never a totally predictive factor. And then they probably stay in some kind of hyper-attentional mode to everything which moves, and then they develop into this disorder. You have here an example. Somebody had a right caloric test called neuritis, otherwise normal, and then he developed into triple PD, and then you get this functional vestibular syndrome. And the treatment is not easy. People don't recover spontaneously on the whole. The treatment consists in giving them an SSRI. The most used one is paroxetine, and to give them vestibular rehabilitation, which tries to very gently increase their tolerance to movement. You mustn't stress these people too much. Talk about mal de débarquement syndrome. That is a French term which has been taken over into English. And that is the phenomenon that people who are in on a boat, often when the sea was a bit rough, and they are fine, but then they come on back on soil, on earth, and then they have the impression that the soil is moving, the earth is moving. And it is like an oscillatory movement, which is present all the time, even when people lie in bed. That distinguish that from many other things. And interestingly, it gets better when they are exposed again to a passive motion. So when these people take a car, for example, they are fine in the car. They get off the car, the symptoms carry on. Or when they go back on the boat, it's also gone. It is very common for a few hours. I'm sure that in the audience, there are probably people who have experienced it, at least for a short period of time. But if it lasts for more than 48 hours, then it is considered like a kind of disorder. And there are people who have it persistent, can have it for months or years. It tends to last longer to regress the more often you had it. And it can also be triggered not only by boats, but also by rides on the plane, or sometimes in the car, or in on games where you are, and and it is still not quite established how to treat that. There are also various studies which are going on that, which combine on the whole also antidepressant and certain techniques of rehabilitation. Some people develop something similar without an exposure to emotion. That is still something which is not very well understood. And now I want to talk to you about popular myth, because that's also important. One of the most common vertigo diagnosis is cervical vertigo. It is in my country. I don't know how it is in Moldavia. And one,
especially the second one, vestibular insufficiency.
Yes. So I want to convince you that these things don't exist, and that you should improve your diagnostic skills. Now, the cervical vertigo is obviously tempting to make the diagnosis, because vertigo and neck pain often come together. That is very common, and neck proprioception plays a role in the vestibular system. And often patients also tell you that they got improvement when they had some neck treatments, although therapy-proven diagnosis is always a tricky issue. That I don't need to tell you too much about that. Now, if we go a little bit along about some common sources of why the confusion comes from. Now, patients will always say, they move their head and they touch their neck and they say, wow, that is painful. Now, you are all sitting there, try to move your neck without your head. There is no natural movement where you can do that. You have to find something very funny, very strange. So naturally, every neck movement is combined with a head movement. As I told you before, lab routine input is totally unconscious. We have a much more conscious experience of our neck than people make this, patients like to make this association, causal association between the pain they experience and the vertigo they experience. But in reality, every movement of your head is a vestibular, or most of them are vestibular neck co-stimulation. So that's the first thing you should be aware of. No patient can feel if it is the head movement or the neck movement which provokes the symptom. And then another thing which is a problem in the scientific literature, that is that most models used for cervical vertigo come from whiplash injuries. Now, a whiplash injury is definitely not an isolated neck injury. The head is accelerated, the vessels in the neck are stretched, the brain is shaken, and so on and so forth. So that is really not a suitable model for a disease. Now, next question, is the neck part of the vestibular system? Well, there is very good anatomical and neurophysiological evidence that the efferents from the neck enter the vestibular nuclei, and they inform on the relative position of the head to the trunk, which is an information the vestibular system obviously needs to modulate its postural reactions and its vestibulospinal reflexes. And so there is the existence of cervico-ocular reflex, cervico-vestibular cervical reflex, all that exists. So there's no doubt that the neck is part of the vestibular system. But we have three potential scenarios about causal links between neck pain and neck disorder and vestibular disorders. So it could be the neck disorder makes the vestibular symptom. We could have the vestibular disorder makes neck pain, or we can have disorders who do neck pain and the vestibular problem. And I'm going to pass through you a little bit reflection on what is likely. Hypothesis: what neck lesions make vertigo? Now, the reality is that has never been found. You can do anything to the neck and you cannot provoke vertigo. So there have been people who have infiltrations of local anesthesia or of saline, you can provoke some vestibular abnormalities, that people have a bit of a staggering gait, or when they have to point to a place that they got a bit of past pointing, but it doesn't provoke vertigo. And also, look what happens. Some of you do treat spasmodic torticollis, or many of you have totally aberrant input from the neck muscles into the vestibular nuclei in this disease, but they don't have vertigo. And when you inject botulinus toxin, they don't have vertigo either. And the ancient treatment of rhizotomies for spasmodic torticollis did not provoke vertigo either. And surgery on the neck, you can do neck dissections, you can take out discs, you can open muscles and stitch them together. You can go through the posterior fossa from the back, where you take all the way the muscles which connect the skull to the neck, and you stitch them together, not in exactly the anatomical fashion they were before. Patients wake up from anesthesia, they are not vertiginous unless there is a problem in the brain. Rheumatic subluxation of the odontoid joint doesn't make vertigo unless the brainstem is compressed, and so on and so forth. So never a nerve, never a structure in the neck has been identified to can make vertigo. Obviously, the vertebral artery, when it is compressed, can make vertigo, but I will get back to that. But a part of the vascular option, anything else, there's no evidence for that. Now, so that is not the case. The other one, does the vestibular disorders make vertigo? Well, the answer is yes. Vestibular patients have usually the problem that when they move their head, their symptoms get worse. So what are they doing? They limit the movement of their head. And how do you do that? You block your head on your trunk by tensing up your muscles of the neck. And when you do that a lot of time and a long time, you are very likely to have pain. So neck pain is usually considered to be a consequence of the vestibular disorders and not a reason. Another reflection is, are there diseases which could actually provoke both? And that the answer is again yes. If you have a vertebral artery dissection, that can make neck pain and vertigo because of stroke. Posterior fossa hemorrhage, rare conditions, can also make both. Orthostatic hypotension can make both. You can have this famous coat hanger headache, which often diffuses to the neck and to the shoulders and the back of the head. And probably the most common, or certainly one common, which is often misguided, is migraine. You know, the trigeminal cervical complex, when it is activated in migraine, can make neck pain as well. Many migraine attacks start with a neck pain. That doesn't mean the pain comes from the neck. It starts in the neck, just as it can start in the eye or can start in the teeth. And since migraine is often associated with neck pain, so is vestibular migraine. So these are the differential diagnoses you should really consider. So number 2 is possible. Number 3 is possible for the combination of neck pain and vertigo. Number 1, no evidence for that. And then this issue of vertebro-basilar insufficiency. Now, vascular vertigo evidently exists, but it is exactly considered like stroke. It's either a stroke or it is a TIA, and there is nothing like a benign vascular vertigo, because we have never defined anything like carotid insufficiency or so as a benign syndrome. Doesn't exist. So we can have obviously TIAs. They can be isolated vertigo, very difficult to diagnose, but just as dangerous as any other TIAs. Stroke can make vertigo in isolation or combined with other neurological symptoms. We will discuss that a bit more this afternoon. Then you have rarer conditions like subclavian steal syndrome. There is rarely a condition of artery compression by eccentric neck position in severely arthrotic necks. But that is a rare condition. I have seen maybe 1 or 2 in my career. So if you diagnose that every day, there's a problem. So issues like sometimes people tell tense muscles in the neck compress the vertebral artery and so on. Listen, that has never been identified as a stroke. I don't think that exists at all. So vascular vertigo exists, but it is a vascular problem like any other vascular problem in the brain. I think that was my last slide. Yes. So I go out.
Thank you very much, Professor Bisdorf. I think it is now rather more clear. This topic, a very difficult, complex topic, which gives us a lot of headache, cervical headache or cervical migraine, we don't know. In our country, also these myths are very popular, still popular. And we hope after your presentation, the diagnosis will be rather more correct. We received several questions, but because we are a little bit behind of time, we'll give you at the workshop, if you don't mind. And okay, and now let me, before we will invite Professor Ludwig Kaposch, let me invite Professor Irina Rektorova. She is the chair of the European Academy of Neurology Teaching Course Subcommittee, to tell us a little bit about perhaps this committee and teaching activities which are running within the European Academy of Neurology. Thank you.
Hello, everybody. Thank you very much, Professor Lisnik, to give me a word. I would just like to greet you, everybody, in the name of Teaching Course Subcommittee. And we are in charge of not only EAN days, but also other activities like teaching courses and teaching education program for the EAN Congress, regional teaching courses, and spring and autumn school. So now the spring school will be during the May 18th to 22, and the topics are movement disorders, sleep, and neurocritical care, for which I would like to invite your young members of the society. And I would really like to congratulate you for coming up with this wonderful program, and I'm enjoying it very much, and I wish you a lot of success with it. And thank you very much for being able to say a few words.
Thank you very much. Our young neurologists for sure will attend to the educational activities within the conferences and congresses and other educational activities which are organized by the European Academy of Neurology. Thank you very much.
Thank you.
It is my great pleasure to invite one of the, if not the leading professor in the field of neuroimmunology and multiple sclerosis, Professor Ludwig Kaposch, working these days at Basel University. He is very known in the field of neuroscience. His Hirsch index is more than 100. Can you imagine? It is due to his publications. He have more than 1,000 published papers addressed mainly to the problem of neuroimmunology and multiple sclerosis. But I will not take your time. Please, Professor Kaposch, welcome. We don't hear you. Please switch on your microphone.
Can you hear me? Hello. Hello, everybody.
Yes.
Can you see my screen already?
Yes, we see you and hear you very well. Thank you.
Okay. And the screen also is visible?
Yes, visible.
Okay. So thank you very much for the invitation. I think it's more than 2 years ago when...
Sorry, Professor, full screen, please.
Full screen, yeah, okay, yeah, okay. So it is, I think, more than 2 years ago since we met, and you asked me if I would be prepared to visit your country and talk to Moldavian neurologists And I was eager to accept and to see your country, which in some way is also connected to Greece, where I come originally and where I am now. The background is from Basel, where I live, but at the moment I am in Greece in holidays. So it's a pity that I cannot visit your country and meet you in person, but I hope that this substitute will help and that there will be another opportunity in the future. So the task that I was given was to discuss updates on diagnosis of multiple sclerosis, which has become again more interesting. We thought perhaps that we have settled with the diagnostic criteria, but we have seen that there are a few entities that I also will touch in my talk, like NMO spectrum disease and MOG antibody disease, associated disease, that we need to separate, and also that we need to look more thoroughly once we have made the diagnosis of MS to better define the cause. And that will be the subject of my talk today. And I hope that this will be to some extent, of course, supporting what you already know and confirming what you already know, but perhaps also some new aspects. So let's start with my disclosures, mainly collaborations in the course of clinical trials over the last 3 decades with pharmaceutical companies, but always at arm's length, as I think it's justified to say. What are the aims of the diagnostic process in MS? Of course, to establish the diagnosis and especially to exclude other better or differently treatable diseases. And then also to characterize MS phenotypes with implications, because this characterization has implications for disease prognosis and the selection of therapy and the prediction of response to therapy. So it's important to further characterize the disease. Let's start with establishing the diagnosis. The basis for all our diagnostic considerations was provided by a committee chaired by this neurologist in the United States, George Adam Schumacher, in 1965 already. And they established the key principles for the diagnostic criteria. We need 2 or more lesions inside the CNS and 2 or more episodes of CNS dysfunction, the well-known relapses, or chronic progression from defined observation time of more than 6 or 12 months. And the third very important part, exclusion of other diagnosis, because the first 2 criteria may also be fulfilled by others. I think it is still true that there is no single diagnostic test that provides definitive proof, but it is always a synthesis of history, of neurological findings, and the results of additional investigations that, of course, in the last years or decade have gained importance. The current criteria that most probably will be revised again or amended in the next 1 or 2 years. A committee I was also part of, this time chaired by Alan Thompson in London, that convened in 2017. The publication was shortly after that. And what are these criteria? Let me recapitulate. First of all, the diagnostic logic that I already explained was kept. So we need to establish that there is a multifocal CNS process, the so-called dissemination in space, adding as examinations mainly magnetic resonance imaging, OCT, and evoked potentials, and evolution over time, or dissemination in time, again by history, and new lesions by examination, MRI, OCT, evoked potentials. And then we also need to establish that the process is an inflammatory, immune-mediated, and therefore we also draw from the results of MRI, but especially, of course, of cerebrospinal fluid examination and showing that there is an intrathecal production of immunoglobulin G. And again, still with all these criteria, no other better explanation. And for that, we need to do additional studies. I will expand somewhat more on. So dissemination in space means that we need more than one or more T2 regions in two or more locations, and these locations that have been defined to be periventricular, cortical or juxtacortical as shown here, and infratentorial, and also in spinal cord. So 2 locations out of these 4 need to be established, so we need to find focal regions in these areas. And the change to previous criteria is that we don't differentiate between symptomatic and asymptomatic lesions. As you may remember, with the former criteria, symptomatic lesions were not counted, and that cortical and juxtacortical lesions can be utilized for for establishing the multiplicity in space. What about multiplicity in time? This is if we see something clinically, symptoms, so that we can also show in a neurological examination, a new clinical relapse would establish the diagnosis, the dissemination in time criteria. We can also see that in MRI. So if we establish that there is a new lesion that was not previous there, this one with a red circle was not there in the previous examination, then this also shows a DIT. And we can also find that there is a multiplicity in time if we see simultaneously some lesions that do enhance with gadolinium and some that do not. So for the first examination of an MS patient, we certainly would be well advised to use also contrast agent, not only the native sequences. In addition, and this is also a change in the more recent criteria, we can establish the multiplicity in time if we show a chronic intrathecal production of immunoglobulin G, which is shown typically with oligoclonal banding. So oligoclonal banding and dissemination in space shown at the first clinical episode will tell us that this is a confirmed diagnosis of multiple sclerosis if we don't have other differential diagnosis. What about progression from onset or primary progressive MS? Here, the criteria, the currently applied criteria, valid criteria, demand at least 1 year of disability progression that can be retrospectively or prospectively determined, and then 2 of 3 of the following, either more than 1 T2 hyperintense lesion in 1 or more area, or more than 2 or more T2 hyperintense lesions in the spinal cord, or demonstration of CSF oligoclonal banding. So 2 of these 3 criteria would suffice together with a 1 year progression of disability over time. So again, you see here the diagnostic algorithm, what can lead to multiple sclerosis, a second event or new MRI with DIT, CSF oligoclonal banding, or second event or new MRI with dissemination in space and dissemination in time. When we talk about clinical proof of evidence of involvement of different areas of the CNS, we should keep in mind that it is not trivial that different neurologists in different countries, in Italy or in Moldavia, will agree on that. And this is an older study in MS, specialized MS centers, where you see here that regarding long tract involvement and brainstem involvement, optic neuritis, the assessments were quite divergent, and the correlation between the findings in these specialized centers in example cases was not as high as at least I would have expected. Let me expand somewhat on the atypical neurological syndromes that should always be taken as red flags and making us doubt about the diagnosis. And I've mentioned some of them. It cannot be an extensive list. You see here cortical blindness, which is more typical for posterior leukoencephalopathy or perhaps PML or multiple infarcts. Hearing loss would always draw our attention to Suzak's or Cogan syndrome. Migraine would also draw the attention to CADASIL or other mitochondrial disease, antiphospholipid antibody disease. Venous thrombosis in the history or at the time of presentation would of course also let us think about Behçet's, Adamantiadis Behçet's disease. Cranial neuropathies where draw the suspicion in the direction of sarcoid or perhaps also Lyme disease or borreliosis. Hemorrhage, tumors, venous infarction can be behind that if we see hemorrhages in the imaging, and if we see myoclonus or rigidity, we would also have to think about paraneoplastic disease, but it has also been seen with Hashimoto's thyroiditis and in a generalized form that involves the CNS. What about other systemic syndromes that also may use as or may serve as red flags in the diagnosis? So occurrence of fever together with the clinical manifestations may lead, of course, the suspicion towards vasculitis, infection, sarcoidosis, systemic autoimmune disease. Then iritis, uveitis may also show or draw the suspicion to sarcoid or PCNSL, and then peripheral infarcts to endocarditis, thromboembolic disease, inflammatory arthritis, of course, more generalized autoimmune disease, but also sarcoid and Lyme disease can cause these symptoms. Livedo reticularis is, of course, typical to antiphospholipid antibody, although in my experience, Livedo is more frequently suspected than really existing. And then a deep venous thrombosis in Behçet's, as already mentioned, and antiphospholipid syndrome, but also in neoplastic disease. And if we see also signs with peripheral neuropathy, something that is extremely rare with multiple sclerosis, not completely unknown, but really rare, then we would in first line think about Lyme disease, sarcoid vasculitis, perhaps also vitamin B12 deficiency. Well, I didn't touch, except for the dissemination in space and time criteria, the use of MRI, but of course it's also very helpful in excluding many of the possible differential diagnoses that we have. And there is an acronym that was introduced by Dr. Geraldus and colleagues from Oxford in the course of Magnim's consensus finding, and which shows which signs in MRI make us more suspicious of another differential diagnosis. And this is meningeal enhancement. Then if the lesions are not well delineated and are increasing in size at short term, then whenever we see macrobleeds and microbleeds, infarctions, cavities, or complete ring enhancement, then symmetric lesions and lesions that spare the U fibers, if we see siderosis and extensive spinal cord lesions. And I think most of you will suspect which differential diagnosis we think about when we see these signs, and this is just shown in this diagram. So if we have possible the suspicion from the clinical picture of MS and we see dissemination in space, then if there is none of these mimics, then we can be quite certain that this is MS. If we see, for example, this meningeal enhancement or an incomplete ring enhancement, then we would think about infection, inflammatory diseases. If we see indistinct, diffuse, fluffy, cloud-like lesions, then we could think about neoplasms and also NMOSD and also MOG antibody-associated disease. Microbleeds and infarcts are quite typical for cerebrovascular disease that we need to thoroughly exclude in these cases, and also cavities and microbleeds and especially small infarcts can be seen also with migraine, as you know. If we have the lesions sparing U fibers or being symmetrical, we would think about leukodystrophies and also about mitochondrial disorders. If we have a clinical presentation that is suspect of multiple sclerosis, but doesn't show a dissemination in space, we can still, if there is none of these mimics, assume that this is possible MS for further observation and investigation. And if we see the distribution of the lesions or lesions where they are, we would need also to look if the localization according to the dissemination in space criteria is given at least partly, and if these lesions are of a specific nature or appearance, then again we would think about these differential diagnosis in first line. Let me talk shortly about two signs that have drawn more attention in the last years, and where we now have sufficient evidence to better use them in the differential diagnostic process by MRI. And this is one of them is the central vein sign. As you know, the first description was early in the last century and then was re-emerged through the description by Adams, who also described that in the describes an inflammation along the venose in a radial form to the ventricles mostly. And we have done in our group, together with Cristina Granciera, we have examined how frequently the central vein sign is seen as compared to inflammatory vasculopathies. And we see here a highly significant and distinctive image. And if you look at the diagnosis in more detail, you see that, again, this is quite nicely differentiating multiple sclerosis from these diseases. But unfortunately, it is not completely specific. In a larger study that was done also with all attempts to avoid other hints to the diagnosis, so the images were divided in different parts so that it was not possible to see if other typical signs of MS, for example, or infarcts were in these images. So in this unbiased analysis, we see that we need to take also into account the quantity, and if 30%, 35% or more of the lesions, the hyperintense lesions contain a central vein, then, and also if we have at least two central vein lesions, then this is good differentiator of MS against mimics and with a high specificity and sensitivity. Just a few examples. I hope you can see that also on your screens that show central vein signs here, typical in MS in 3 different captures, here axial, sagittal, coronal slices. And as you see here, another patient with antiphospholipid syndrome, and you see here that we are lacking this sign, and here a patient with Sjogren's disease or systemic lupus erythematosus, where again we are not seeing, although without this special sequence, we would not be able to differentiate the morphology of the lesions here by depicting here with 3 Tesla MRI the central vein sign. We can gain specificity in the images. Here you can see a comparison between Behçet's disease and multiple sclerosis, and you see that the picture is not as clear as that because we see also central vein, but less frequently, and that's why I alluded already to the fact that we need to take the quantity, the number of these lesions into account. Here, a typical MRI of a migraine, and you see that these white matter lesions are usually small and non-confluent in deep white matter, and that they are sparing the U fibers. And they are also more stable over time. There is not such a change or reappearance of new lesions without in the spontaneous course of the disease when we have a migraine with these hyperintense lesions. And we usually would not expect to find cortical or spinal cord lesions. This is an example of a 34-year-old patient with migraine with aura. Age-related cerebrovascular disease lesions, of course, can also mimic to some extent, but you see here these hypointense lesions indicating bleedings, and you see this cuffing, which is quite unspecific, and also temporal lobe, and then the distribution of the hyperintensities according to vascular territories, and of course then the angiography shows that there is a clear-cut vascular involvement. This busy slide depicts some of the differences between neuromyelitis optica spectrum disease and MS. First of all, of course, you are familiar with the definition. The typical definition of multiple sclerosis and NMOSD, I don't need to recapitulate here. In NMOSD, we would expect to have a positive antibody to aquaporin 4 IgG. If we have the typical clinical picture of neuromyelitis optica, then we have also those that are NMO seronegative patients. If some of those who are in the spectrum of NMOSD and do not show the antibodies are still in the same category is still a matter of debate, and you have seen also that the response to the treatments in controlled studies was much less pronounced, if at all significant, in those patients who did not show anti-aquaporin 4 antibodies. Usually NMOSD patients are older than MS patients, and they are always, the onset is always with relapse, and it is still doubtful if a chronic progression is there, a secondary progression or not. Usually the disease evolves in episodes with partial remissions and without intermediate between the relapses and progression of the disease. But there have been described some of these cases, and maybe this is also an overlap syndrome to multiple sclerosis. Usually we would not expect white matter lesions, but if they appear, they are more unspecific, and usually also if we find them in the hypothalamus, in the splenium corpus callosum, so more in the middle part of the brain and brain stem. If they appear in the hemispheres, usually they have and show enhancement. This is more cloud-like, so not so well delineated. In the typical sign, of course, of NMO is an extension of the lesions in the spinal cord over more than 3 or more vertebral segments. And usually we wouldn't see oligoclonal banding, only in about 10 to 15% of patients, but some pleocytosis. And if we have the possibility to analyze for GFAP and IL-6, usually at least during the exacerbations, this is increased. We also see much more frequently coexistent autoimmune diseases in NMOSD patients. So let's see the distribution of lesions in the MRI. You see here the diencephalic lesions, then dorsal brain stem lesions, sometimes extending to the cerebellum, as you see here, with the, and then callosal lesions in typical cases shown here on this slide. And here again, some other features, sometimes tumefactive lesions, not so well delineated, and more spindle radial. Then we see also cystic lesions, and the extension here over the corticospinal tract, as you see here in this image. And you see here also the enhancement that some of these overall rather rare cerebral lesions can also show. Here you see a typical spinal cord images with an extensive lesion here over several segments, and here a nearly full involvement of in the axial view of the spinal cord. What about anti-MOG disease, which has come to our attention more recently? First of all, of course, a mainstay of the diagnosis is the antibodies, which are highly specific, but depending on the lab to some extent, but also in general in non-active phases can also disappear. And so the sensitivity is lower, but the specificity of these antibodies is very high. If we want to differentiate against MS, we would expect less than 3 brain lesions. A very recent, not yet published Magnims study has shown that the differentiator is 6 lesions. Probably because we have used more recent images with higher resolution scans. So up to 6 brain lesions is a quite good differentiator. And again, the appearance more fluffy cloud-like than the distribution over the brain stem, pons, or areas adjacent to the 4th ventricle, and typically also the cerebral peduncles are phenotypes or in MRI for MOG antibody disease. Here you see also some images of an acute disseminated encephalomyelitis, not only in children. This is an adult patient with multifocal bilateral asymmetric T2 hyperintensities, and also involvement, as you see here, quite clearly involvement of U fibers, and both supra and infratentorial lesions with frequent contrast enhancement. Interestingly enough, not so frequent involvement of the corpus callosum in ADEM. So in summary, MRI is still the main additional investigation that supports MS diagnosis. Although we now have re-included in the official criteria oligoclonal banding, it can help in the MS differential diagnosis, especially if we observe this mimics criteria characteristics. And I didn't expand on that. It's also important in the observation or in the vigilance for adverse effects of treatment, and especially early recognition of PML, and in the course of PML, recognition of iris that may then make specific therapeutic measures necessary. So let's turn to the second part of what I wanted to discuss in the context of the diagnostic process. We need to characterize the MS phenotypes. And here we are still relying on a committee I was also part of, chaired by Dr. Lablin from New York, that divided the causes of MS into relapsing and remitting according within this group to active and non-active at the time of investigation. And activity is defined by relapses or new and enlarging MRI, T2 lesions or contrast enhancing lesions. So these two criteria, and then has changed our definition of progressive MS by throwing away the progressive relapsing MS group, and by blurring somewhat the boundaries between primary progressive and secondary progressive MS. Progressive MS is characterized by the co-appearance together with progression of disability, of activity with the same criteria that are used to describe activity in relapsing MS. So active and non-active progressive MS is distinct, and then within these groups we can also have times or periods where the disease disability is progressing or not progressing, of course, depending also on the granularity, on the sensitivity of the measures that we apply. Yeah, I think I can skip that. So if we, especially secondary progressive MS and the transition to secondary progressive MS has gained again interest. What are the established diagnoses historically? First of all, the group of with a Canadian London, Ontario group description led by Ebers had defined secondary progression after a relapsing course at least 1 year of continuous deterioration. And there is the Cambridge definition with 2 consecutive sustained accumulations of disability events, the second from the new EDSS baseline, independent of relapses, and then the established the Lablin committee criteria with steadily increasing, objectively documented neurologic dysfunction and disability without unequivocal recovery. An attempt to do that based on real data, on a large data set, is done by the MS base group by my colleague Johannes Lurscheider, who's now working with us in Basel. And the definition that emerged as the most reliable, combining sensitivity with specificity, was 3 or longer confirmed EDSS progression in absence of relapse. Then at least 1 step in if pre-progression EDSS was lower than 6 or 0.5, if 6 and more, and an EDSS of reaching an EDSS of at least 4, the pyramidal functional system score of at least 2. These criteria certainly have advantages because they have a high accuracy as compared with consensus diagnosis by several clinicians who agreed on the diagnosis finally. Then with this diagnosis still, although it is quite strict, SPMS was diagnosed in this group of patients of more than many patients in the MS base the registry 3 years earlier with a consensus diagnosis, and it is reproducible. So you can see, you can count, and then you find it. But the disadvantage is that it is weighted towards motor and lower limb function as the EDSS on which it relies. That the EDSS may, different assessors may come to different results, so the reliability is not always established, although in this group they all were trained according to the neurostate and certified, again, according to the neurostatus criteria. And at the end of the day, it was a group of more than 20,000, but those who qualified, patients, but those who qualified for the definition of the criteria was a small group, and they didn't include any MRI data in this definition. And at the end of the day, if we need to wait until someone has an EDSS of 4 and a pyramidal functional system score of 2 until we make this diagnosis, it may be too late also for therapeutic interventions. Regarding primary progressive MS, the current criteria I had already alluded to, and they are quite similar also to the Thompson or McDonald criteria. At least 2 of the following need to be established together with disability progression: 92 lesions, or at least 42 lesions and pathological visual evoked potentials, 2 or more lesions in the spinal cord, or CSF oligoclonal bands. I have already alluded to that previously, just for recapitulate. One problem that is not yet really reflected in the definition of progressive MS is that we find progressive features already in typical relapsing patients. And we have had the privilege to see that perhaps in the first time in a group of patients followed for long term in the top study with natalizumab, and then also under controlled circumstances where every patient was examined according to the same scheme, a standardized way every 3 months in the ocrelizumab pivotal phase 3 studies. And there we saw that still, although this ocrelizumab was very effective in suppressing relapses and also MRI activity, there was an increase in disability, especially if we didn't look only by the EDSS, but also by additional measures, the 9-hole peg test and 25-foot walk test. And progression or confirmed progression in one of these criteria would fulfill the criterion of progression. And you see here on the graphs what we observed. We observed, first of all, the black line on the left in the interferon, approximately 30, 35, and 29% of the patients had confirmed disability progression at the end of a 2-year observation period. This was lower, only 21% with ocrelizumab. But the most interesting in this context finding was that in nearly all the patients and a very high percentage of patients in the interferon group and nearly all the patients in the ocrelizumab group who had disability progression did so without any relapse. So it was a relapse independent progression, which we call PIRA, and only a very small percentage, 6% here in the interferon and 3% in the ocrelizumab group, that progressed in temporary association with relapses. So in typical relapsing patients, we have progressive elements that may be better uncovered by an effective immunomodulating treatment. But for these features, the current definitions are not well suited. And on the other side, we have more and more indication that recognizing this progressive element already in at least a part of the relapsing population may also require a better or call for a better treatment or another treatment, a change of treatment. So therefore, it is still very important to recognize that. And just to support my case, in another program with ofatumumab, also an anti-CD20 study that was done against teriflunomide, we see exactly the same phenomenon here with 3 months confirmed disease worsening or 6 month confirmed disease worsening in both groups. And we see that the highest percentage was with PIRA. So of the progressions that in this case were only based on the EDSS, approximately 15 to 10% in teriflunomide and ofatumumab, you see that the great majority of these progressions were again PIRA. So this has something to do with the continuum of the pathogenesis. And the former view that we had that there is a stage with pure acute inflammatory events, and then it goes, it transforms into a chronic and less inflammatory phase, has to be revised. We know that both elements, acute inflammation and chronic and more trapped inflammation in the CNS, may coexist, and they may coexist from the first manifestations of disease. Signs of that have also been observed in radiologically isolated syndrome, so before any clinical manifestation of the disease. Clinical manifestation is, and I think this is also important to take into account, dependent on not only on the acuity and quantity of the damage, but also on the compensation and reorganization potential of the individual, and therefore a clinical stability or recovery may be deceiving for the real process or the real destructive process. Yeah, I don't want to expand on that. I think I made the case that we need, in order to recognize the development of the disease, not only these criteria, but in applying these criteria and expanding on these criteria, we need a thorough, continuous clinical monitoring. And this has relied on standardized physician-based assessments as the EDSS, but we'll need to rely more and more with the development on the administration of comprehensive digital biomarkers. So the physician-based monitoring, you are well familiar with the EDSS scale that is graphically depicted here. We have invested quite an amount of energy and time into standardizing these assessments, especially for clinical studies, but also for studies done in cohorts of patients, prospective observation studies, and also more recently included an electronic form that provides a feedback if there is a consistency in the ratings. But still, we have problems with that to really understand what happens with the disease. And therefore, digital monitoring of progression beyond EDSS and other scales, clinician-applied scales, is necessary. And in this, we can capitalize on features that nearly all smartphones that have now entered or are now used by nearly everybody in the world can be used. So these contain high quality sensors that gyroscopes, magnetometers, and also GPS in most cases that help together with registering touch, light, sound, can be used to monitor the development of the disease. And you see here in red the clinical investigations that happen with the red signs here. And here you would see the results of a continuous assessment with digital biomarkers through a smartwatch or a smartphone. You see that you have much more informative results that allow you to better understand the evolution of disability. We have embarked in Basel into a new project where we are assessing through smartphones and activity watches the different features of the disease. So for example, movement, fine motor skills, very interesting for cognition because we can apply that to easy to perform and also with a character of games, also better accepted cognitive tests, vision tests, and also questionnaires through the smartphone, in addition to the passive monitoring, in order to use that over time. We are just starting a large study after a first feasibility study where we assess that in comparison to state-of-the-art physician-based measures, also laboratory measures like neurofilament light or magnetic resonance imaging, including advanced imaging, in order to see if really with this approach that would be easy to apply for people in their homes, in their normal environment, we can really gain valuable and important information. Important in the whole approach is that this is taken up by patients, and for that it should be more of a game, something that you like to do, not only because you think that it is important for your disease. And the idea is to create in parallel a platform where this information is taken together with information by physician assessments, by other paraclinical tests, and used both for therapeutic decisions and information of people with MS. So with this glimpse in the future, let me complete my talk also by alluding to other possible biomarkers for inflammation. We can see that with more modern, with more recent, with established, but also with more recent methods of imaging. New methods of imaging can also provide information about the state of the myelin in the CNS and also on the rate of remyelination with quantitative MRI techniques. And of course, as we know, with multimodal evoked potentials, we can also assess the function of the conduction velocity and perhaps also to some extent quality. Axonal and neuronal damage is depicted by atrophy, some time already used, and by new advanced imaging methods, but more importantly by OCT, as far as it is seen in the background of our eye with this very sensitive method, and with more and more evidence supporting the specificity and usefulness of this measure with neurofilament lights in blood. An area that is still in development, but certainly important, also in correlation to the real clinical deficit, is the loss of synaptic plasticity, disruption of functional networks, where we can use more sophisticated methods on one side of functional MRI with necessary informatics behind that, and also quantitative EEG, multi-channel EEG can contribute to better assess that, which is of course important in order to define also the rehabilitation potential of our patients. So let me, at the end of my presentation, thank our group here in the hospital garden in Basel, and a glimpse to the Rhine that you see also in the background of today, and also to thank you for your attention.
Thank you very much, Professor Kapos. We apologize for disturbing you on holidays in Greece. It's very nice time there. But anyway, thank you very much. It was a 2 years time schedule between our agreement and the presentation, what to do. We thank you for accepting anyway our invitation. One short question before the break. Professor Gavrilyuk asks if the diagnosis of multiple sclerosis could be established only on the basis of damage of the spinal cord in absence of cerebral lesions.
Strictly no, because we need to show dissemination in space, and for that we need at least 2 regions of the CNS that have been shown. It is still in debate if showing that oligoclonal bands are in the CNS, specific for the CSF, are there. This could be included. Actually, it has not been used to replace dissemination in space. Therefore, I would say officially no, but I also am aware and treat patients who have this specific feature, and it is always an issue also with what treatment to choose and if to choose or not, and also perhaps with authorities or with payment for the treatment. But these criteria are necessary to agree across different neurologists and different countries, but there will be always cases that do not really fit into that, and we personally are convinced, and I think as long as we are able to differentiate from other differential, to exclude other differential diagnoses, we are justified to include them.
Thank you very much. In the former Soviet Union, the classification was of MS was like cerebral form, spinal form, and mixed cerebrospinal form. So it existed such a form only spinal, but it was perhaps a classification before the use of MRI.
Yeah, and in a purely myelitic manifestation, of course, you need even more thoroughly to exclude nowadays NMOSD and also more antibody-associated disease.
Okay, thank you very much. And we are awaiting the workshop, which will take place with you at 2:30 p.m. It is our time, and perhaps as well Greece time. We are on in the same time zone.
We are in the same time zone. That may have caused the misunderstanding. So it's a different time zone than Switzerland. You are in 1 hour in advance. Okay, that was the reason why we had this complication this morning, because I thought you are in the Middle European time zone.
Thank you. Sorry, so we're expecting you at in 2 hours and 15 minutes.
Okay, thank you very much.
Thank
Sorry
you
for the misunderstanding. Yeah.
Thank you. And now we invite the representative of the residence and research section, Dr. Alla Ivanyuk, who is coming from our neighboring country, from Ukraine. We don't know exactly from which city you are coming, hopefully not Donetsk, because our team, Sharif, beat it yesterday in Champions League, Donetsk Shakhtar 2-0. It's a surprise for our football. Thank you.
Thank you for your kind introduction. So my name is Alina Ivanyuk, and I'm coming from actually the neighboring region in the Ukraine. So I'm from Odessa, and I'm a teaching assistant and the junior consultant in the University Hospital in Odessa, but today I'm speaking on behalf of the community of young neurologists of the EIN. And let me show my screen. So, do you see my presentation? Is it visible?
Yes, it's
Okay.
visible.
Excellent, thank you. So again, I'm speaking on behalf of the community of young neurologists of the EIN, and during the next 20 to 30 minutes, I will update you on the possibilities that EIN provides to young neurologists and tell about the RRFS and what to expect from this community and which opportunities it grants. So I looked through the list of participants and I was glad to see participants of the past EIN schools and former clinical fellows of EIN. That's nice, and that really shows that Moldavian young neurologists are active. But if you are unaware of the activities of EIN, please stay tuned. We are about to discover them. So here is what we will cover, and we will start with what is the research the resident and research fellow section. So it is a subdivision of EIN. So RRFS is a subordinate of the EIN office, and it aims to represent and inform neurology trainees and young neurologists across Europe. It also aims to facilitate clinical training and research abroad. So if you are willing to spend some time abroad studying something, that is the right place for you to start. It also aims to improve the training of neurologists in different countries and to connect young neurologists for clinical exchange, and of course to build a platform for communication among young neurologists. And what it is and how it all works together. So at the center here you see RFS office. And our RFS office is represented by the treasurer, the person who is responsible for budget and financial issues at RFS. Then there is secretary, who is responsible for communications, internal and external, within RFS and senior EIN officers and with external societies. And there is a chair. A chair is an official representative of RFS, and he or she is the main person who is responsible for all the affairs of the organization. And the past chair is actually the active participant of the community and of the office. He or she coaches the other office representatives to guide them through all the process, because the person who is elected to the treasurer then the next year becomes the secretary, and the secretary becomes the chair. So the treasurer is selected each year, and then he or she moves across this ladder to become a higher representative in this hierarchy, so to say. Then there are committee representatives. EIN committee is a group of people, a group of neurologists, individuals who work on EIN initiatives. For example, there is a teaching course subcommittee who governs regional teaching courses. There is education committee, which governs the organization of schools and other educational activities, etc. And each of these committees has a young representative. Then there is a young representative in each of the scientific panels. And the scientific panel is busy with creating guidelines, with reviewing current evidence and creating recommendations based on the most current evidence, and also facilitates introduction of those new recommendations into different societies. And of course, there are also young representatives there. Then there are representatives from each country, of the countries, and of course there are regular RFS members, which can become any of those. So you also can apply for any committee, any scientific panel, for RFS office as well when there is a call. So keep keep your eye on your email box. You might receive an invitation soon, and you might be able to apply. So here is our office for 21-22 year, and the next year Alice will move here to become the secretary, Nina will move here to become the chair, Luca will be past chair, and this place, the treasurer, will be vacant. That means that you can apply for this position and become the next treasurer, which is an amazing opportunity to work with other EAN officers. All of them are excellent neurologists and excellent mentors, and this is a great opportunity for you to grow professionally as well and to expand your network. We already have representatives in committees and in scientific panels, but this can change anytime. And again, if you receive the mail stating that we are searching for a representative from RFS, here is what you need to send, and here are the criteria you need to satisfy. So if you study or work in a European country, and if you are the member of the RFS community, you just send the CV, motivation letter, and proof of your RFS membership to the RFS email, and you will be considered for the position. We already have the representatives in almost all the European countries except for Finland, Hungary, Bosnia and Herzegovina, and Montenegro. The national representatives are approved by the National Society. So the head of the National Society has to send an email to the RFS inbox stating that this person has been approved by the National Society to represent the young neurologists in that country. Or if the Young Neurologist Society is present in that country, the Young Neurologist Society can issue such a letter, which anyway has to be sent to the RFS office for that. And this is something new we introduced this year, or last year. Last year, the Students' Task Force was introduced and created. So EAN is now governing also students, and students have already had, but anyway, they have 3 membership possibilities, so they can join EAN for free. And this year, there is also a fellowship for students. So if you are mentoring a student or a group of students, please inform them that there is an opportunity to apply for student fellowship, and that's the same as clinical fellowship for young neurologists. We'll talk about that a bit later. And they can come to another country and train there already being while they are students. So that's an exciting opportunity for them. EAN RFS office also keeps relationships with other international organizations, the other junior neurologist associations. Such associations exist in Switzerland, in Germany, and in Italy, with International Neurology Association, with Cochrane Neurological Network, and with European Board of Neurology. EAN RFS office regularly organizes events at the EAN Congress, so there are separate activities accessible only for young neurologists, and make sure you do join those events at the next Congress because they are fun and educational, and this is an excellent opportunity to network. RFS also conducts surveys, and surveys are basically on education. So those surveys aim to detect flaws in the neurological training across Europe and to address them. So here are some surveys that have been conducted in the past year, and here are some current surveys. And if you want to also participate in those surveys or help organizing those surveys, reach out to the RFS office. Here is the email. Of course, give thumbs up to our page on Facebook and subscribe. The page is updated regularly, and you can be informed about the RFS activities through that page. Now, the most important thing, how do I become a member of RRFS if I am not a member yet? So you should be eligible for that. And everybody who is a resident in neurology, research fellow in neurology or neuroscience, or a PhD student in neurology or neuroscience, or is up to 3 years after the latest degree is eligible to apply. And let's say if you are now a resident, if you finish the residency, work, let's say for 5 years as a neurologist, and then you decide to apply for a PhD, and now you are a PhD student, you are still eligible to apply. The cap age, it is not indicated here, but the maximum age at which you can apply is 35 years. People who are older than 35 years are, in my opinion, still young, but unfortunately, they are not eligible to apply for the membership. And you should send all those documents indicated here with proof of eligibility. That's just a statement from your program director or your mentoring physician on the letterhead paper of your institution that states that you are indeed a trainee at this institution and that you are in good standing there. You should either mail all those documents here at this email, or just go to the EN website, find the resident and research member page at the member packages tab and click apply, and you will be headed to the application system. And members have many benefits, such as free teaching courses, the possibility to apply for all the teaching activities of the EAN, and that's for a pretty low price. So as low middle income country, Moldavian residents are eligible for lower price. And the second year is for free. So basically that's not a big price for such great benefits. And here are the counts of the RFS members from different countries. And although Moldova is not the first one, considering the sizes of Moldova and the number of young neurologists there, that's a pretty good number. So I hope that it expands after my today's talk. And if you are already the member, do not forget to renew your membership until the 28th of February of the next year. Okay, so now the most interesting part, the educational opportunities. Each year, there have been 2 regular schools, so the spring school and autumn school. The autumn school is led in Greece each year. Unfortunately, last year it was online because of all the COVID restrictions, but it will be led offline, so in Greece this year. All the accommodation, the program, everything is covered by EAN. You only cover the flight if you are selected. The same for spring school, and spring school is always led in Austria. Unfortunately, it was online last year, but anyway, this year it will be on site, and everything is the same. You should apply until the deadline, and the deadline, I think it is still possible to apply. You just apply, wait for the result, and if you are selected, you pay for your travel and come and enjoy the educational program and networking, let's say in Austria. Another thing that is not indicated here, unfortunately, the slides are not updated, is the scientific school. So there is another scientific school that will be held for the first time next year in March, and the application is still open, so you can apply also for the scientific school, which will be led also in Austria, in Salzburg this year. The next activity is regional teaching courses, and the regional teaching courses bring EAN community to a particular country, and all the EAN renowned speakers head to that country to share their knowledge during several days in that country. And usually each day is devoted to a separate topic, and it is possible for everybody from the neighboring countries to also to participate. And one of the next teaching courses will be led in Liverpool in the United Kingdom in April. If you are considering something closer to you, you can gladly join the teaching course in Odessa, Ukraine. We will be very glad to house you if the COVID-19 regulations allow, and we do hope that they allow you to cross the border and to join us in November. We'll be glad to house you and to govern you and to share this educational experience with you as well. Now, we also have some online educational opportunities. We have the system that is called eBrain, and eBrain is world's largest, most comprehensive based training resource for neurology and clinical neuroscience. It is a set of interactive modules that you can access anytime on your pace and learn something new. There are many modules which cover all the fields of neurology and are completely free for EIN and RFS members. We inform about our activities also through EIN pages. This is an official resource, an official blog, and electronic newspapers of EIN. You can follow it online and be informed about our activities as well. Another educational opportunity is European Guideline Education and Cost-Conscious Healthcare Program, or COCO Care Program. This is an excellent program for you to learn how to develop guidelines. And you have already seen that any young participant of any RFS member can become a member of the guideline development group. And to know how to develop guidelines, you can join this program and learn how to develop guidelines. The last year, it was held online, so you didn't have to leave your country to participate in the program, but usually it occurs on site in the EIN office. So you'll have to leave your country for some time and go to another country and meet other participants. And this is another great opportunity for you to network and to expand your network further. Now to the fellowships. And fellowship is a sort of educational opportunity, but it stands apart because it is indeed a very, very particular experience. So you find the information about the fellowships here at the separate tab, fellowships and funding. And what is a fellowship? A fellowship is an opportunity for you to travel to another country to train yourself in either clinical fellowship or research fellowship aspects of neurology and neuroscience. And clinical fellowship usually lasts for 6 to 12 weeks. It is funded by the grant, and the grant is €525 per week, and also the travel expenses are covered. To participate in the clinical fellowship, you should be eligible, first of all, for that, and you should be you should have at least 2 years of training or be within the last 3 years of your latest subspecialty degree at the time of the application. So, for example, if you had the PhD training, you are eligible 3 years after the PhD training. You should be accepted by an approved host department. You will find the table with all the departments that are available there on the EIN website. Of course, you should be the RFS member. And this is important. You should find and contact the department before you apply. So first you contact the department, you ask if they are okay with you applying for the fellowship, and you will then come to them for training. If they approve you and they give you their approval, you can then apply for the fellowship. And the same is for research fellowship, but first of all, you need your research program or research plan, and you have to work this out with your host department. Notably, the clinical fellowship does not exclude the possibility of research. So during your clinical fellowship, you can also be involved in the research activities. This is not forbidden. In the research fellowship, it is pretty hard to be involved in clinical activities, especially if you are applying to purely academic facility, for example, to a laboratory, but there are ways to organize clinical activities as well. This is to work for you to decide and to work out with your mentor at the hosting institution. So again, if you are a resident of neurology with a minimal training of 2 years, or you have completed your degree, but no more than 3 years has passed, then you are eligible to apply. Of course, you should be fluent in either in English or in the local language of the institution, and most of the institutions do require the local language. So in the table listed in the on the website of EIN, you will find those criteria, and you will find out whether they require the knowledge of the local language or not. And importantly, if you have already participated, you are not eligible to apply. So this is a one-time opportunity, and do use it wisely. And now to the available grants. And you will find that the bursaries here under the grants and awards tab. There are Congress bursaries. Every year, EIN provides 240 bursaries, and which cover the registration, the travel expenses, and the living expenses for the time of the Congress, and who are eligible, again, PhD students, residents in neurology, or people who have finished the clinical training 3 years, who are within 3 years after the latest degree. And also it is possible for our colleagues from other countries. Now there is so-called European Board Examination in Neurology, which is held during each Congress every year. And it is a sort of a examination that proves that you are competent in all the aspects of neurological training in Europe. It is a sort of certification that you are knowledgeable in neurology. It is not designed for you to it can be a useful addition to your CV, but it does not serve as a substitute for any legal requirements for neurology practice in other countries. So you can take it, but it's a sort of a good proof that you are knowledgeable, and it's a good addition to your CV, but it is not. It does not allow you to practice neurology in other countries if you are not eligible to do so otherwise. So there is also a possibility to apply for this grant and to pass the examination for free. And to do that, you should have a short CV, proof documents that you have applied for that examination, that you have been accepted. So first you apply for the examination, and then for the grant, you submit the copy of your passport. And you should also state that you haven't received any other financial support. This is an unofficial sort of form that you have no other sources of funding. And here is more info about this EBN exam. And again, this is additional sign of excellence, but it does not impose any legal consequences. So with that, you do not attain the right to practice within European Union or elsewhere. And then there are travel grants to attend other conferences. And if you attended a course or a congress that significantly improve your clinical or research skills, you can ask EIN RFS to reimburse that. And 8 grants are provided each year. You just send the documents that are listed here, so motivation letter, CV, approval of the participation in the congress or course, and stating that you have not received any other funding to the RFS office. So again, you first apply for the congress or course, and then you ask for reimbursement at the RFS office. And hopefully this year's or the next year's already, Congress will be held on site, and it will be in Vienna, in Austria, and we are all hoping that it will be indeed on site, and we are looking forward to seeing you all there. And again, a reminder, please join the RFS activities. And with that, I would like to conclude my talk. And yeah, we are open to any questions, but I wonder if there is still time for that. If no, please reach out via our email.
Thank you, Alina. After your presentation, it could be a problem. Nobody will remain in our country. Everybody will go to study somewhere abroad in the next year or near future. We'll see.
Yeah, we will see. But anyway, I think that this intention to go abroad and to live abroad comes from within, and you cannot prevent it or foster it with any kind of activities. And if it should happen, it will happen. But anyway, everybody should remember that working even if in low-income country opens possibilities to pioneer in something and to improve the quality of healthcare in the country. And maybe that can also be a very satisfying thing, and even more satisfying than moving abroad. So keep that in mind. Yeah, and thank you for your attention.
Thank you. Now we have the break for lunch, and we'll meet each other once again on the same link at 13:30, at 1:30 p.m. So 45 minutes of break. And you may not disconnect. We will use the same connection. Thank you, and see you at 1:30 p.m. Off to go.